Hi, everyone. Thanks. We're just going to take one more minute or so to let attendees start filtering in, and then we're going to get started. Thanks for joining us this morning. Just a quick reminder, we have a few panelists who are logged in. Thank you so much for joining us. We will be moving some panelists down to attendee and then back up to panelist throughout the day, just to keep the screen a little clean and to make sure that the sound is as optimal as it can be. So if you see that you've been moved to from panelist to attendee, don't worry, I did that. Okay, it looks like we've got a good number of folks in, so we're going to get started. Thank you so much for joining us this morning. I'm Megan Lechkowski. I'm from PA Families Need Nurses Now, which is a program of Vision for Equality. I'm going to just stop talking myself and throw the morning over for a welcome address from our friend and supporter from the city of Philadelphia Intellectual Disability Services. They're semi-new. Some of us are just meeting him, Director Kleckner Charles. Kleck, take it away.
Good morning, everyone. It's a pleasure to be joining all of you on this great Monday morning. It's actually gonna be pretty warm where I am, and I'm sure probably gonna be pretty warm a lot of places, so stay cool. I wanna say it is a true pleasure for DBHIDS to be partnering with Vision in this initiative. Next slide. I want to start by just going over the mission and vision for DBHIDS. DBHIDS, our mission is to educate, strengthen, and serve individuals and communities so that all Philadelphians can thrive. And our vision, we envision a Philadelphia where every individual can achieve health, well-being, and self-determination. Remember the vision part. About 20-something years ago, there was a young man who was working in an ICF. ICF stands for Intermediate Care Facility. 12 individuals. A lot of those individuals came from, institutions, state developmental centers. And the young man just started right out of college, wasn't sure what career path he was actually going to select. And he became very inspired after sitting down to attend back in New York State what we call the AMAP class, which is the Approved Medication Administration class. There's a similar curriculum in the Commonwealth, although the name escapes me. But basically, it's a 1-week class followed by a series of practicum, which allows direct care staff to be able to give meds in a community setting such as an ICF or any other type of licensed group home settings. Upon being able to take that class, this young man felt very inspired, being able to keep the individuals under his care healthy. It's not just giving them habilitative support, meaning helping them to do their ADL, going into the community, but it actually has a control and a certain level of support and assistance regarding their overall healthcare. That became very inspiring. Let's pivot to the present. This young man is me. Out of that experience, I've made a career in the field, and I've encountered a lot of wonderful individuals. The nurse who did the training, and other nurses that I've encountered. And I've partnered with nurses. I've battled with nurses in team meetings, arguing one perspective versus another. We've had challenges, but it's all with the same mission, with the same goal in mind, for the better health and for the overall improvement and well-being of the individuals that we support. I want to say this by saying that your work that you do as a nurse is not just, a nursing care plan, training staff, following doctor's orders, but there's something else you don't see. You inspire others. You make it possible for others, such as me, to have greater meaning in the work that we do. Next slide. Our system of care is presently at a crossroad. Even before COVID, we had a direct care staffing crisis. To my research within the past 2 years, I've learned that nationally, there's a turnover rate for direct care staff, which can be as high as 66%. And a lot of people who go into our field end up leaving it because of not only poor pay, lack of support, and also very difficult work. And also they have other options that will pay more. This direct care support crisis affects not only providers who are dealing with the turnover rates, but also affect family members. I've learned through an NCI survey that was done, the most recent one, I believe 2018, whereby 97% of caregiving families, basically families who have elected to keep their loved ones at home, have reported some challenges in terms of finding competent and consistent direct care staff to help them support their loved ones at home. And providers are no different. A lot of them have a lot of issues regarding turnover. I know in Philadelphia, we a lot of at least a couple providers have reached out to us in terms of consolidating group homes to make it possible to be able to continue to provide support in a safe environment. And on top of all of this, you also have an aging population. And the aging population doesn't just affect baby boomers. A lot of the baby boomers also include people that we provide support to, people with ID, people who are on the spectrum. And in fact, it's predicted by 2040, we'll have more people over the age of 65 than we have people under the age of 18. What that will mean? It will mean there'll be a greater strain in the need for nurses. There'll be a greater strain in terms of finding ways to provide competent nursing support and competent care for people to remain in their home, remain in smaller settings. Next slide, please. What are some of the possible consequences? If someone cannot be cared for safely in the community, what will we be left with? We'll be left with the hospitals, nursing homes, psychiatric centers. And that's not a place where we want any of our loved ones to be supported. And especially when the person can be supported effectively and safely in the community. And also much higher costs. It's well documented. It costs a lot higher to support someone in those institutional settings as opposed to what we call in Philadelphia a CLA or even a smaller ICF. It costs a lot more to support people in institutions. And also, no matter how competent and how fully staffed those institutions are, it's when you compare it with the level of care that's being provided in the community, it is substandard. The people in the institutions are devoid of community connections. Their sole connections are basically the staff coming in, whether it's the 3 to 11 shift or the 12-hour shift, overnight shift. Basically, that's primarily their connection. Someone who's in a nursing home setting or a hospital setting or psychiatric setting. And also lack of other social connections. If someone lives in a CLA, they end up indirectly forming other connections. The neighbor will say hi to them. The male person, I mean, a little bit less so now because of COVID, but it's getting back to normalcy again. And some of the population that are most vulnerable are the medically frail population. And a lot of nurses on this webinar know what I'm talking about. Someone with a G-tube, someone with a trach, someone who's has uncontrolled diabetes and requires insulin injection, someone who's on a vent. Those individuals will be the first ones being admitted into nursing home, and they're the most vulnerable in those settings. It's been in recent decades, we've been talking a lot about social determinants of health, and it's shown social isolation leads to increases of other diseases. So we want to avoid that. Next slide. Next slide, please. What are some of the positives of effective support, nursing support in the community? Greater life expectancy. I can tell you, I remember having a conversation with a parent many years ago. And the parent said to me, one positive that my son is getting better care in the community or in the group home that he's at. But what's also going to happen, I'm afraid that my son is going to outlive me. I'm saying this to say that prior to COVID, I feel, suffered some setback as a result of COVID. The life expectancy of someone with ID is approaching your average life expectancy. So what does that mean? It means there's a greater number of baby boomers who are individuals with ID and individuals with autism. And also that has led to greater deinstitutionalization. The initial wave of deinstitutionalization mostly included people who were more or less, agile and did not require nursing care, did not require a lot of support in the community. So with the advent or the proliferation of nursing support, it made it possible for greater deinstitutionalization and again, greater smaller settings. By smaller settings, I'm talking about group settings of 4 people or less. Back in the 80s or 90s, they were like mostly ICFs, 14 bed, 12 bed. But now, even if you look in Philadelphia, ICFs are almost like passe. And also it made it possible for having greater unpaid support, meaning it's easier for mom, dad, uncle, and aunt to maintain a connection with the loved one who lives in a CLA as opposed to a 100 bed nursing facility. And also greater access for medical support. Because of nurses that's available in the community, someone doesn't have to remain in a hospital for long following surgery. They can be discharged, so whereby the nursing support will follow them in the setting where they are at. So these are all positives of nursing support in the community. Next slide, please. What will the future look like for us? If we had a crystal ball. Some of this is some independent research that I've done in my recent studies. Virtual technologies will play a big role. All we have to do is look at what's happening in the hospital settings. You have EICU, basically virtual ICU, whereby the intensivist or the cardiologist is basically not even at the hospital, somewhere else, hundreds and dozens of miles away. Our field has to be willing and engaged to be able to adapt some of those technologies. We need to not find a way to educate our stakeholders, which will include parents, which will also include the individuals receiving support, and also include the AE, people from DBHIDS, people from ODP, people who are responsible for some of those funding. Prior to COVID, a lot of times virtual care is not funded at the same rate as care that's provided on site. But virtual care can also make it possible for a nurse to be able to support a lot more individuals that they could if they had to go from CLA to CLA, drive from one place to the next. It would make it a lot possible. It would make it a lot possible for the direct support staff to receive more in time support from the nurses. I can tell you from a personal standpoint, a couple of years ago, we engaged with a large virtual health provider, and I was shocked that their stethoscope, that you can actually, the physician or the nurse could be remotely and then ask the direct staff to just put the stethoscope on the heart, on the chest of the individual being supported, and it will be just like they're sitting right there doing the examination. So we have to be open to all of those. And also there are some more passive virtual technologies that'll be put in place. We gotta be receptive to those as well. I know there are a lot of concerns regarding privacy. We can help work through those. And I can tell you our everyday life is already being invaded anyway. I can tell you each time I get in my car and Google usually tells me thanks where I'm going. We have to be mindful of that. Medication compliance will also be being open to a lot of technology to help us with this as well will be very crucial. And a lot of our nurses will have to be open to using a lot of those technologies. So if you're going to visit from individual to individuals, you'll basically have a little handheld, which will tell you a lot of the history. So basically we have to be open to embrace it. Next slide, please. In closing, I want to say that your role is very instrumental. You are a pillar in our field. Your work not only is getting our individuals to be healthier and stronger, but it's also inspiring others. Your work will make it possible for us not to have any Olmstead implications. By Olmstead, it's basically cases that have gone all the way to the Supreme Court, whereby the Justice Department have challenged individuals' ability to live safely in the community and away from institutions. Nationally, we have a waiting list for the waiver in excess of 600,000. Having ample nurses coming into our system and remaining into our system will make it possible for the waiting list to go down. And you will continue to inspire your coworkers, your colleagues. And thank you. And we're looking forward to continuing to partnering with you. And in our own office, we presently have a unit that engages with some of our more difficult to support individuals. That unit has mostly been focusing on individuals, what we call BHID, behavioral health and intellectual disabilities, people who are dual diagnosed. But we'll be looking now to expand that to include at least one staff who's also helping to look out for individuals who are medically frail and individuals who are looking to transition out of nursing homes, individuals who are medically frail, who are looking to live more meaningful lives in the community. Thank you all.
Thank you so much for that. And that's wonderful to hear. I appreciate that your office is sort of expanding its view and looking to include the more medically complex population and supports in the community. That's really wonderful. We've always been so grateful at Vision for Equality, and more recently, PA Families Need Nurses Now. We're a newer program of the support from DBHIDS, and we continue to look forward to this partnership. I just wanted to take one quick minute to see if anybody in the audience had any questions or comments before we move on to our roadmap. Today, we will be using the chat feature, which we'll talk about a little bit more. Several folks have already started sending some chats about technical issues. So we know that it's working and that folks are using it. But it looks like everybody took your words and they are taking it in, and they're understanding where you're coming from. And we thank you so much for being here with us today and welcoming our group here. Thanks, Kleck. Please stick around. I know, I guess you're a busy guy.
I will drop back in and out.
Stay with us for as long as you can. Thank you so much.
Thank you. Bye.
As we move on through the day, we have our wonderful advisory council member, Dana, is going to be helping me with the slides today, and she's got us here on our roadmap. So just a quick overview, we do have a jam-packed day, and we are very excited to bring you the content that we've put together. So I don't want to take too long. Everybody has access to this. We will be dropping a link to the agenda for today in the chat. So if we want to move on to the next slide, we'll go over just a quick practice and some information about how to utilize the chat for those who aren't familiar. We just want to do a few housekeeping reminders. We've all been using Zoom and similar platforms for over a year now, so I know a lot of this might be repetitive for folks who have been accessing the world remotely and from a video perspective for quite a while now. But just to be sure, we always think reminders are helpful. We ask that everybody who has the capability to unmute themselves stay muted during the session. Sound is always a struggle on these large groups. So if everybody stays muted, that helps make sure that all the presenters and panelists and video presentations can be heard as best as possible. If you are joining by phone and you wish to raise your hand to speak or let us know that you'd like to make a comment, you should be able to press *9, and that will allow you to alert us that you'd like to speak. You can utilize the chat feature throughout the presentation to add your comments or to ask questions. And I believe Dana is sort of circling the little area. If you look to the image on the right of the screen on the bottom, there is it looks like a little thought bubble with 3 dots. That's how you open your chat feature. And we can practice now, actually. I'm a former teacher, so I always love to check for understanding. So if everybody wants to jump into their chat, and the agenda is now linked above. So if you wanted to follow the agenda for the day, Victoria has sent everybody a link to the agenda on our website. And if we want to try now to use the chat, if everybody could type in what county they live or work in that they're tuning in from. We'll take just a minute to allow people to, there we go. We have some folks from Philadelphia County, Montgomery County, Chester County, Philly again, Elk County, Delco, Washington, Green, Fayette, Allegheny, Lebanon, Dauphin, Bucks. If we get to all 60 some, we're golden. Thank you. I appreciate everybody taking that time to practice. That is going to be the best way to communicate with us throughout the session. And we do hope that we get to be a little interactive. I know that's tough through a screen, but utilizing the chat function has been successful in the past in allowing folks to share their comments, share their thoughts, and to ask questions in the moment that we can come back to when the time is right. So if we do ask that if you share, to try to keep your sharing brief. We have a lot of folks on today, and sort of keep it related to the topic that's being discussed. We all have so many concerns and issues and so many things we're passionate about. And today we'd really like to focus on the need for the direct care nursing workforce, and how we transform that service in Pennsylvania to make sure that folks who have medical complexities and disabilities and medical complexities have the opportunity and are supported to live in the community where they deserve to be. So moving on, this is a safe place for all. I asked that folks share briefly, but we want to make sure that we're also welcoming honest feedback and dialogue, and we're striving to support everybody who's present today. We want you to feel comfortable sharing, and if to do so, you'd rather not identify yourself by your full name, please feel free to rename yourself on your screen. You can name, you can say anonymous, or put your initials, or put that you're a Bucks County family or a Montgomery County provider, whatever you'd like to use. You don't necessarily have to identify yourself by person if that makes you feel more comfortable sharing. And we just want to always make sure that we're honoring everybody's perspective. Everybody's lived experience is different. So we're going to maintain respect for all, and just make sure we factor in all perspectives that could be coming to us today. Next slide. We are, throughout the session, going to engage you and try to keep you alert by engaging you in polls. So we'd like for you to participate in a poll right now. You should see it on your screen. It's been launched. And it's just a quick question. Did you attend the 2020 Nursing Summit last year? Yes, no, or you don't remember. And that's fair if you don't remember. We were in the height of the part of the shutdowns. So I hardly remember that I was at the summit last year, and I was doing exactly what I'm doing now. So it looks like we have, oh, cool. It looks like we have about 33% of folks so far who were at the summit last year and are joining us again this year. Thank you and welcome back. And we have about 65% of folks who are new to the summit. So we welcome you, and we hope you take away some valuable information and some new perspectives today. All right, we can share those results. I'm going to share the results real quick so everyone can see. Here we are. So I want to say, we have a good amount of folks returning, and we have a greater amount of folks who are new. One of the things we're very excited about as PA Families Need Nurses Now is that we've, over the last just a quick introduction to us if you haven't met us before. My name is Megan Lechkowski. I am the mother of a 7-year-old boy named Miles, who relies on a tracheotomy and a ventilator, a G-tube for feeding, to remain home with us. And he, since his first discharge from the hospital 6 days shy of his first birthday, he has been able to remain home with us thanks to the support of in-home, highly skilled nursing. And that has been a struggle. That workforce is dwindling. And unfortunately, the pandemic has not made it any better. COVID-19 has decimated what was already a struggling workforce, and has put a lot of pressure on already struggling and families who are worn thin. So we're excited to come here today and bring everybody together to continue to problem solve and try to come up with long-term solutions to how to make this a more tenable situation, so that kids like Miles and adults who were Miles as a child have that support, so that they can be here at home with their mom and their dad and their brothers, and go to school with their peers. None of that can happen for my Miles, without home nursing. And I know very many families in Philadelphia and across the state who are struggling in the same way. So, for those of us who were here last year, this video may be familiar to you. And for those who are just joining us for the first time, we'd like to share this just as a reminder of why we're all coming together today.
Having nurses at home that are aware of their role impacts our life tremendously, because without them, Abby wouldn't be able to stay home. And Abby has a very active life, and she's healthy because she gets one-on-one skilled nursing.
And home nursing has afforded us the opportunity for Brandy to get her care in the home. So the continuity of her health care has enabled her to have a better and broader community experience.
You are not allowed to take a trach child home without a backup caregiver, and it's just me.
But we can't make it to work. We can't take our other children to school if we don't have the support of home care nurses.
My daughter was able to go on prom because the nurse was willing to come in on her own time and go with her.
My other children are safe because I can get the rest I need and can be there for them as a mom and can just focus on Miles's kid needs and not always just his medical needs.
So when you have a good nurse, we can trust that person to stay with Riley, and we can go do something, maybe even have like a date, something that we don't do very often.
So they impact us 1,000%.
Nurses are important to have a job Monday through Friday. I wouldn't be able to do all that if I did not have a nurse.
When I have dependable home care nurses, I'm able to just be mom.
Thank you so much for joining us and reviewing that video. I know a few folks in the chat asked if there was a way that they could see this video or share this video. Victoria, if you don't mind sharing the link to the video in the chat so that everybody has access, we would be honored and excited for you to share that video. It was a labor of love for us, and it does share the story of several of the families who were the impetus of PA Families Need Nurses Now. So please share away. We have one more poll. Well, we'll have several polls throughout, but we want to bring everybody back and engage in another poll just now. Thanks, Dana. Which of your roles brought you to the Nursing Summit this year? You should have a poll up on your screen. Now, it could be that one or two or three of these apply to you. I would say, whichever one feels the most right in the moment. Which one feels the most right about today? What brought you to this summit? Looks like we've got several parents or caregivers of folks who rely on home care services. We have a few home care nurses. Hello, thank you for joining us. It's always so tough to get folks from the workforce here and part of our events because you're also pulled thin. There's not enough home health nurses in the field, and thank you for joining us today. We really appreciate your perspective. We have some agencies, some nursing agencies who thankfully are out there coordinating services for many of us, some insurance companies, nurse training programs. I'm so happy to see that we have lots of folks here from government agencies or departments that serve the disability population, and even more from non-government agencies that serve the disability community. We need your support, and some others. So if there are any Lost fans out there, that's a real old reference. Don't pay attention to me. So it looks like we have a really wonderful mix of folks here, and that, I couldn't be more delighted about that, because it's really going to take the entire community to transform what we know as home health care into what we know home health should be. So we can stop the share of those results and move on. We're really excited over the last few years. PA Families Need Nurses Now, which, as I started to say earlier, was born out of a group of parents who came together at the first nursing summit to share our testimonials, and who were also moved and motivated by each other, that we stayed connected. And through the supportive vision for equality, we were able to create this grassroots family-driven effort to address the shift nursing crisis in Pennsylvania. We're rooted in Philadelphia, but all of our loved ones and those of us who are supported by in-home services are often served by the state in some way. So this is, we're an organization rooted in Philadelphia, but we encompass a statewide focus, because we have to build these partnerships, and we're grateful for these partnerships that we've been able to make with state organizations and departments over the last 2 years. And one of the wonderful partnerships and relationships we've been able to grow is with Senator Bob Casey's office, who's been wonderfully supportive of the work we do, and has drawn on our experiences to be sure that he is championing the needs for home and community-based services in PA and across the country. So we have a special message for all of us from Senator Bob Casey.
Well, I'm Senator Bob Casey. I want to start by thanking PA Families Need Nurses Now and Vision for Equality for inviting me to speak to you today. The COVID-19 pandemic expanded our understanding of the work done by and the stress placed on an overworked and underpaid healthcare workforce. It helped us to develop a renewed appreciation for the workers who support children, young people, and adults with disabilities and complex medical needs. The skilled home care nurses who provide services and supports to your children and families are essential workers, and we need to recognize their value. We entrust home care workers with the lives of our loved ones, but we support a system that does not justly compensate their work and their profession. Home healthcare workers provide skilled hospital-level care in the safety of the home and the community. These workers deserve not only the respect and gratitude for the frontline work that they performed during one of the greatest periods of crisis our nation faced in generations, they also deserve the compensation their peers in other parts of the healthcare industry enjoy. Older adults, children, and adults with disabilities and their families know the value of home and community-based services. Some refer to it as HCBS. They also know that the individuals who provide that care are so valuable. This is a time for home health care workers, the disability community, older adults, policymakers, and supporters of home and community-based services to come together to finally push for a permanent extension and expansion of these services, and better pay for the people who are providing them. Access to home and community-based services can change the lives of millions of people, but it takes a dedicated workforce to achieve that kind of care. The dedication of the thousands of women, in particular women of color, who largely make up the home and community-based services workforce, are paid just $12 an hour. That's the national average, $12 an hour. That is unacceptable in America if we're going to call ourselves the greatest country in the world. So whether in the midst of a pandemic or part of an average day of care, this workforce is helping to keep people at home and part of the community. So we have an obligation to lift that workforce up, to pay them in accordance with the value we claim to place on their essential work. Whether a younger individual with a disability or an older adult, many of us will likely need access to some level of home and community-based services in our lives. HCBS can help individuals stay home and out of nursing homes and other congregate settings. Home and community-based services also allows individuals to access the healthcare and support services they need from the safety of their own homes. And home and community-based services also provides a lifeline to older family caregivers to receive support and to limit the need to take their family member to appointments outside the home. These services offer more than mere convenience. They are a lifeline for communities at risk of losing their independence. This option is not only cheaper for everyone involved, but more importantly, the benefits of being able to live in the community of one's choice result in better health outcomes, higher life satisfaction, and longer lifespans. Our nation needs a bold investment to strengthen home and community-based services, and to strengthen the home and community-based services workforce, and to better support the millions of people who rely on these vital services to live full and independent lives. I fought for an increase in HCBS funding from the start of the pandemic. And then later, once he was president, President Biden recognized the importance of home and community-based services funding through a $400 billion investment in or as part of, I should say, the American Jobs Plan. Now, this $400 billion investment builds on the nearly $12.7 billion investment in home and community-based services that was in the American Rescue Plan and that I fought to include. But we have a lot more to do. This funding that we just started to make part of our policy now with the Rescue Plan, this funding will make it possible for more people with disabilities and older adults to live in their own homes, participate in their own communities, to go to school, to hold a job, to receive the care that they need, and choose where they want to live. The American Jobs Plan recognizes home health and home care workers as a vital component of our nation's economy, and it seeks to adequately compensate and value this essential work. The President's proposal makes an investment in the caregiving economy in a manner unlike we've seen in many decades. We have a responsibility to advance transformative change and transformative solutions that allow individuals accessing home and community-based services and the workers who provide these services to not only survive, but to thrive. I think this is a mission worthy of a great country. But in order to get this done, we got to pass legislation. And we're a ways from that. We have to do a lot more work. I'd ask you and encourage you and really plead with you to engage your members of Congress, House members and senators. All of you here are passionate about this issue, but to advance permanent support for home and community-based services, and to advance the urgent needs of that workforce, we will need to keep building support in Congress. So don't just contact them once, contact them multiple times, engage their staff, and probably most important, tell your story, or in some cases, more than one story. Tell those stories. They are the most persuasive testimony that will help us pass this needed investment, this long overdue investment in home and community-based services for our seniors, for our loved ones with disabilities, and in order to lift up the caregiving workforce. Thank you, and God bless your work. Well, I'm
Thank you so much to Senator Casey's office for coordinating that video for us. The senator was initially hoping to be here live, but we know how those schedules go, and we were so grateful that they were able to coordinate that pre-recorded address for today. You heard the senator talk about home and community-based services and the caregiving workforce, the infrastructure of a caregiving workforce. And you'll hear us talk about that a lot today. Because we are at a really unique time where there's a lot of federal discussion around home and community-based services, which are the types of funding and services. That's the type of legislation that provides for the type of skilled nursing and shift nursing that support families like mine to keep their loved one at home, going to school, in the community, being a part of the family, in the place they belong, where they want to be. So, you know, this is a very exciting time. We are we're looking at ways to take the momentum of this federal discussion around home and community-based services and translate that into transformative transformative situation here in Pennsylvania around home and community-based services. We have another speaker today who was due to be here live. Elena Hung is the co-founder and executive director of Little Lobbyists, which is a wonderful organization. If you're not familiar with them, please look them up. Elena, you know, she was due to be here this morning to deliver our keynote address, and this weekend, today being the birthday of the ADA, the American with Disabilities Act, turns 31 today. And Elena was invited to come to the Oval Office today to speak about these very issues that we are talking about right now. So, you know, she had a little bit of a better offer. No, she was very distraught that she couldn't be here with us today, and she was wonderful enough to provide this recording for us, and we're excited to share it.
Hello, friends. Hi. I am so excited to be here following Senator Casey's remarks and giving the keynote address at the 2021 PA Nursing Summit. Thank you, PA Needs Nurses Now, for inviting me and for the amazing work that you do. I am honored to speak with you, and I'm thrilled to be part of such a wonderful community. I am Elena Hung, better known to some of you as Xiomara's mom. I'm also the co-founder and executive director of Little Lobbyists, a family-led group advocating for children with complex medical needs and disabilities. You know, as I reflect on the past several years, I am feeling more energized and hopeful than I have felt in a really, really long time. Allow me to share a bit of my journey with you leading up to this moment. In many ways, my healthcare advocacy story began in early 2017. Like so many across the country, I was watching the news about the Republican healthcare repeal efforts then, and I got really scared and worried and angry. And in a moment of hope and desperation, my friends and I showed up on Capitol Hill one day to tell our healthcare stories. My daughter Xiomara and I and other families with children with complex medical needs and disabilities wanted to put a face on healthcare, wanted to put a face on those who were alive because of the Affordable Care Act and Medicaid. So we collected stories, healthcare stories from families like ours from across the country, and we hand delivered them to members of Congress. We had planned on just one lobby day, but that one day quickly led to another and another, and Little Lobbyists was quickly born. In the weeks and months, and yes, years that followed, my friends and I, we showed up. We kept showing up on Capitol Hill. We showed up at every rally and press conference that we could get to, both in DC and across the country. We grabbed every mic that we could get our hands on. We talked to every staffer and member of Congress that we could chase down. We spoke to the media. We wrote op-eds. We even learned how to use Twitter. We wanted everyone to hear our stories. So here is my story. 7 years ago, I had a great pregnancy and an amazing birth. And then 15 minutes after my baby was born, She was placed on 100% oxygen support and rushed to the neonatal intensive care unit, where she remained for the next 5 months. She was diagnosed with serious medical conditions affecting her airway, her lungs, her heart, her kidneys. I named my baby Xiomara, which means ready for battle. She is definitely that, and she is the joy of my life. I am so lucky that I get to be her mom. Now, Xiomara uses a tracheostomy to breathe and a ventilator for additional respiratory support, a feeding tube for all of her nutrition, and a wheelchair to get around and explore the world around her. I am thrilled to tell you that Xiomara is thriving today. She is happy, kind, funny, clever, and a little bit naughty. Xiomara recently graduated from the first grade, attending school via distance learning. She celebrated her 7th birthday this summer. Wow. These are 2 milestones that were never guaranteed to us and that I am forever grateful for. And I'm so grateful for our access to affordable quality health care, including Medicaid. It was Medicaid that paid for the home skilled nursing that enables Xiomara to live at home with her family instead of an institution far, far away. And because of that, she's had the opportunity to grow up with her big brother, tons of friends from the neighborhood, and a community that loves her. You know, I won't pretend it was easy. Xiomara was not sick enough to be inpatient at a hospital or facility, but she was sick enough to require an awake and alert, skilled caregiver round the clock. That's 24 hours a day. Someone who was trained in tracheostomy care and who knew what to do in case of an emergency. And in this case, an emergency meant life or death in a matter of minutes. Her room at home was filled with equal parts medical equipment, medical supplies, and baby toys and stuffed animals. There are lots of unfilled nursing shifts that left Xiomara's dad and I pulling overnight duty night after night, day after day. There were nurses who were not properly trained. It was hard, but my family is lucky. We survived those early days and Xiomara thrived. And this gratitude makes me think about power and representation. I think about the stories that get told and who gets to tell them. And I think a lot about what Congresswoman Ayanna Pressley says. Those closest to the pain should be the closest to the power. I'm going to say that again because I just love it so much. Those closest to the pain should be the closest to the power. Now, no movement for social justice has ever succeeded without the full participation and leadership of those most directly affected. And that is certainly true for the health justice movement. That is power. So friends, own your power. If you are ever feeling powerless, remember that your voice is your power. Use your voice. Tell your story. Sometimes using your voice means being loud and persistent. Sometimes it means getting on the red line and taking the metro to Capitol Hill to speak with your senator for the very first time. Sometimes it means knowing your story will put a face on policy. So you get up on stage to take the mic, or make a phone call, or write an op-ed, or have that difficult conversation with a family member or neighbor, even though you're nervous and scared. Sometimes using your voice and using your power means passing the mic to center the voices of those most directly affected. It means elevating the voices of those who have been historically and consistently left out of the conversation and the decisions that affect them. My advocacy has been informed by my daughter and is centered on the disability community. There is not a single issue, whether it be healthcare, immigration, climate change, criminal justice, gun violence, education, employment, voting, not a single issue that does not impact the 1 in 5 Americans that live with a disability. At the core of everything I do and believe is that we are only true advocates if we engage in inclusive advocacy. So when I advocate for healthcare for those with complex medical needs and disabilities like my daughter Xiomara and her little lobbyist friends. That includes immigrants with disabilities, LGBTQ people with disabilities, people of color with disabilities, people of all faiths with disabilities, those living in poverty with disabilities. And that means all disabilities, whether it be mobility, sensory, mental health, intellectual, or developmental disabilities. It includes our friends with chronic health conditions, in recovery from substance abuse, and those living with trauma, because all means all. Using our power means uplifting and centering all of these disabled voices, however they define their disabilities, however they choose to communicate. As my friend Julia Bascom says, there is no such thing as the voiceless, only the unheard and the silenced. So let us all commit right now to using our power so that everyone is heard and no one is silenced, because representation matters. And that brings me to impact. How do we define impact? Well, I tell you what, together we saved the ACA. Together we saved Medicaid. We did that. The impact is collective. The impact is personal, deeply personal. My daughter Xiomara relies on Medicaid, and what that means is that she gets the life-saving care she needs. It also means that she gets to grow up at home with her family in a community that loves her. I'm not forced to ship her off to an institution far away, which is what routinely happened to disabled kids like her not that long ago. That's what Medicaid means to her. That's what Medicaid means to me and my family, and that is why we need more funding for home and community-based services, including skilled nursing at home, to achieve healthcare justice so kids like Xiomara can survive and thrive. We saved the ACA, and we are here now with an urgent mission to ensure that healthcare is indeed a human right, to improve and expand to a universal healthcare system that works for everyone. Right now, we have a once-in-a-generation opportunity to make a life-changing investment in home and community-based services and solidify that caregiving is an essential part of our infrastructure. That starts with a $400 billion investment in President Biden's American Jobs Plan so that our kids with complex medical needs and disabilities can thrive. This is a historic opportunity, and this can change and improve the lives of disabled people, and we must fight for it as hard as we have fought for anything. This is the time for states like Pennsylvania to use this national momentum to lead the way in creating a real caregiving infrastructure. That is impact. Impact is elected officials and members of Congress understanding our humanity and lived experiences alongside the data and numbers. Impact is a seat at the table where decisions are made. Power, impact, now. Now. The time is now. The time is always now. We have so much work to do, and we need to keep going. We did not come this far to stop now. We didn't start to stop. Time is now. I know that we've had some really scary times. We witnessed the fragility of our democracy. At the start of this year, we witnessed a violent racist coup attempt in our beautiful capital, a building so many of us have fallen in love with during our lobby visits to Washington, D.C. We witnessed our friends and families experience terror and trauma when the previous government relentlessly attacked our healthcare the past 4 years. We're still in a pandemic that is disproportionately affecting Black, Brown, Indigenous, and disabled communities. We are hurting and we are mourning. All of this is very real, and we're all coping in different ways. And through it all, we continue to advocate, we continue to speak up, we continue to tell our stories. And like many of you, I'm going to continue to do the work. Like you, I am attending events like the PA Nursing Summit. Like you, I'm having energizing conversations with colleagues in other organizations, and I'm having hard conversations with elected leadership. Now, I'm going to work hard because the work is important and urgent. But, but, but I'm also going to play hard and find joy wherever I can. Now, I'm going to laugh and dance and love and have fun. So I'm going to leave you with this. While there will always be dark days, and there will always be a few who try to destroy what we hold sacred, there are many more of us who are trying to create a world where there is justice and equity. There are way more of us trying to create a world where we can be joyful. And if we're working on the latter, but deny ourselves the joy in the process, then we're missing the whole point of all this. If we're fighting for our kids to survive, but not thrive, then we're missing the whole point of all this. We can do both. We can survive and thrive. We can work hard and play hard. We can advocate for comprehensive funding for home and community-based services, and we can enjoy quality time with our loved ones in our homes and in our communities. So friends, go on and find joy. Create joy if you must. Give yourselves permission to feel joy now, because joy is an act of resistance. It is. It has been an honor to share my words with you and to fight alongside you. Thank you. Thank you all for your time today. Thank you for the powerful work that you do. Thank you for the impact that you make. And thank you for the joy that you bring. Thanks, everyone. Be well.
So wonderful words from our keynote speaker, Elena Hong, who reminds us that this is important work and that no voices are more important here than those who are experiencing the experience, who are having the experience. The lived experience is like nothing else when planning and programming for a population. And you know, those of us who are family members or individuals who are struggling to get services right now, it can feel so exhausting and isolating. But you know, it is really important to find those moments of joy. So thank you to Elena. Thank you to Little Lobbyists for being such a wonderful partner. Nicole Harris is going to, I moved you back up to panelist, Nicole. Very quickly, you know, we've had a lot of talk about home and community-based services so far already, and what that means on a federal level right now. Our friends at Pennsylvania Health Access Network, which is a wonderful organization that does community health outreach, they are hosting a virtual town hall with Senator Bob Casey tonight around the Better Care, Better Jobs Act, which includes legislation around home and community-based services. So if you were interested in finding out more, you can visit the Pennsylvania Health Access Network website or their Facebook page and join in at 5 p.m. tonight for a town hall with Senator Casey around this very issue. So without further ado, I want to let Nicole Harris, our next speaker. Nicole is the Executive Assistant of the Office of Medical Assistance Programming, and Nicole is heading up the Shift Care Initiative, which is an initiative that was started in 2019, where Office of Medical Assistance Programming, otherwise known as OMAP, launched into this introspective project with stakeholders from across the state and across the healthcare industry to try to reach conclusions and solutions around the pediatric shift nursing crisis. Nicole's also going to share with us some updates about the American Rescue Plan spending plan updates from Pennsylvania. So Nicole, take it away.
Thank you, Megan. Can you hear me good?
You're great.
Good. Good morning, everyone. I'm Nicole Harris. I serve as the Executive Assistant to Deputy Secretary Sally Kozak for the Office of Medical Assistance Programs, also known as OMAP. I am here on behalf of the Deputy Secretary this morning to talk a little bit about how the Pediatric Shift Nursing Initiative started and where we are now. To begin, I will give an overview of the initiative, and then we will take a closer look at each recommendation in detail. Next slide, please. Our Deputy Secretary wanted to address the challenges facing children living with complex medical conditions that are receiving in-home pediatric shift care nursing. She saw this as an issue when she previously worked for the department, and now as Deputy Secretary, she wanted to help improve the system. When the initiative began, it was Sally's mission for OMAP to serve as a catalyst for stakeholder collaboration. She hoped that in providing a forum for key stakeholders to identify issues and barriers, it would also serve as an opportunity to develop actionable solutions that can improve our pediatric shift nursing model to better serve patients, families, home health care workers, and our managed care organizations. In June of 2019, a kickoff meeting was held to begin conversations regarding issues surrounding the delivery of pediatric shift nursing care. The first meeting started with a handful of representatives from some of the home health agencies and the managed care organizations. They met that day to share their experiences and concerns and to brainstorm on ways to move forward. As a result, this initial group of stakeholders quickly expanded to include families, advocacy groups, physicians, health systems, additional home health agencies, and a few other key stakeholders. If you look along the bottom of this slide, you can see all the participants. Out of that first meeting, several key themes emerged: service coordination, transition and discharge planning, caregiver and nurse relationships, behavior and physical health coordination, and nurse recruitment and retention. Work groups were established to further explore and develop recommendations for each of the identified key areas. The work groups met regularly and made progress. Even during the global pandemic, the participants remained committed and persevered with virtual meetings. Everyone has done a lot of great work and should take great pride in the efforts that got us here today. If you can go to the next slide, please. In November of last year, a white paper titled Improving Pennsylvania's Pediatric Shift Care Nursing Through Collaboration was presented to then Secretary Miller. The white paper was the result of this stakeholder-driven initiative that has sought to improve Medicaid service delivery for some of Pennsylvania's most vulnerable children. A copy of this report can be found at the department's website under the Documents section. The recommendations and ideas captured in this white paper were the result of thoughtful discussions and sharing of personal experiences. Working across organizational boundaries has provided all the participants of this initiative the opportunity to learn new perspectives and build and foster existing connections and relationships. The recommendations included in the white paper were accepted by Secretary Miller in December. In collaboration with the DHS executive team, OMAP prioritized the recommendations and identified those that were most feasible and likely to have a significant impact in addressing improvements in coordination of the pediatric shift care and the shift nursing shortage in Pennsylvania. In January, OMAP began planning on how to move forward with implementing the prioritized recommendations. At the bottom of this slide, you can see just a few milestones that we identified. In May, we conducted a virtual stakeholder meeting to provide updates on these ongoing efforts. In June, we submitted proposals to CMS for American Rescue Plan Health Home and Community-Based Service Funding. And in July, we sent a letter of support to Pennsylvania nursing schools. I will elaborate more on these milestones later throughout the presentation. Next slide, please. This slide highlights the recommendations developed by the work groups based on the problem statements the groups identified. In the next 5 slides, we review the problem statements, the recommendations, and the current state of each. Next slide, please. First, we have service coordination. This work group focused on challenges surrounding the role of the service coordinator, the process for care coordination, and the resources needed. To address these challenges, the work group developed 2 recommendations: provide service coordination options and consider developing an assessment tool specifically for children receiving shift care services. The work group recommended that every family should be given the opportunity to receive their service coordination through a medical home or through their managed care organization. Each option should cover each of the 7 essential elements identified by the work group as screening and identification, outreach and informing, assessment, individual planning, case management, assistance assessing services and supports, monitoring, follow up, and oversight. We began by exploring the current state of medical homes in Pennsylvania using these elements as a guide. In our research, we have explored the NCQA certified medical home, the patient centered medical home model currently outlined in our Health Choices Agreement, and the American Academy of Pediatrics Pennsylvania Medical Home Program. Currently, we are evaluating each model to determine which one best suits the needs of the families we serve. Each model has its own benefits and challenges concerning implementation, and we are still researching funding options and the necessary resources providers will need to become a medical home. We plan to reach out to managed care organizations, home health agencies, and providers to better understand the gaps in the current care coordination process and to determine how the medical home model could potentially help address those issues. In addition, we're looking at how internal operations in OMAP can ensure family choice is being offered to every child receiving shift nursing support. For the pediatric assessment tool, rather than mandate an existing tool, we decided to work with the managed care organizations to discuss developing their own version of assessment tool for standardized implementation. Our next steps for the service coordination implementation include clearly defining relationships between care coordination structures, completing research for monitoring, incentives, and enforcement, and identifying the medical home model to highlight in service coordination. Next slide, please. Next, we have the Going Home Transition Work Group, who proposed 3 recommendations, which are to provide best practices for discharge, to improve co-vending scenarios, and incentivize onboarding of home health agencies into Pennsylvania's Patient and Provider Network, also known as the P3N. We are exploring the development of a pilot program to conduct with MCOs to evaluate implementation of the discharge checklist developed by the work group. We are linking this to service coordination as a way to ensure that the service coordinator will utilize or encourage hospitals to use the checklist during going home transitions. Additionally, we are evaluating different methods for streamlining communication between home health agencies, managed care organizations, and families at the time of discharge. We are researching effective strategies to begin the discharge process in a timely manner so that everyone involved are well equipped for the transition. We will reach out to relevant stakeholders to discuss the current discharge processes and to identify methods to improve coordination during this process. Furthermore, we are working internally at OMAP to understand how some of the communication issues between home health agencies, managed care organizations, and families could be alleviated through the use of the P3N and what could potentially be developed within the health information exchange specific to this service delivery. Next slide, please. Here we have the caregiver and nurse relationship area. In this work group, some of the challenges identified were the lack of communication between caregivers and the shift care team and establishing a safety net for missed shifts. The 3 recommendations established by this group were to increase ongoing family input, expand the care plan, and create a training and education portal for caregivers and nurses that specifically focuses on the pediatric shift care cases. To increase family input, we decided to explore the creation of a statewide family council at the department level. This could potentially look like the formation of a statewide committee to ensure specific attention is paid to this population. Additionally, we are exploring how to best expand the home health agency level model of a family council and the utilization of family peer educators. We continue to research potential opportunities for ongoing consumer input focused on pediatric shift nursing. For the care plan recommendation, we are working on developing health choices agreement language on expanding the focus of the 485 care plan to address a whole child plan of care. OMAP is discussing if the expanded care plan can be a part of the patient provider network. Finally, for the creation of the training, portal for the caregiver and nurses. We are consulting with our ODP partners to explore the potential to mirror their My ODP portal. Next slide, please. Our Behavior and Physical Health Work Group discussed the importance of increasing awareness of behavioral health within the pediatric shift care nursing field. The vision statement of this group was to ensure that children with complex medical conditions receive whole person care. We have been talking with behavioral health training experts to determine appropriate behavioral health training for shift care nurses, keeping in mind that nurses are not delivering behavioral health services, just assisting the families and getting the support they need. Furthermore, we are identifying multiple intervention points to ensure behavioral health is discussed with the family, such as during authorization and or during biannual face-to-face meetings with the managed care organization special needs units to help increase behavioral health and awareness and assessment if needed. The second recommendation developed by this group was improving the integrated care process. The work group suggested that the integrated care plan that is currently used to foster collaboration between physical health and behavioral health managed care organizations for adults with serious mental illness could be adapted to pediatric shift care cases with behavioral health needs. Our team has been meeting with OMAP and the Office of Mental Health and Substance Abuse staff to understand how to incorporate and adjust aspects of this program for the pediatric shift nursing population. Future steps include working with the special needs units to better understand how behavioral health services are being coordinated as a part of the case management functions. Furthermore, we continue to explore the structures and the features of a pediatric integrated care plan. Next slide, please. Lastly, we have our fifth work group, nurse recruitment and retention. The focus of this group was to address two specific concerns: the inadequate supply of nurses in PA and the need for specialty education in pediatric home care. Most of the focus on this work group's recommendations were to engage nursing schools. A letter of support was drafted by this work group to engage Pennsylvania's nursing schools about collaborating on shift care nursing education. The letter was sent to nursing schools this month. We have asked interested schools to respond to the letter by August 20th. We hope to begin the conversation of how we all can work together to address the shortage of nurses in this field. Furthermore, our OMAP is internally reviewing the list of regulatory changes and strategies outlined in the white paper to strengthen the home health workforce. If you can go to the next slide, please. Finally, I want to spend a few minutes on the American Rescue Plan. The American Rescue Plan of 2021 provides a temporary 10% increase to the federal medical assistance percentage for certain Medicaid expenditures for home and community-based services. The funding must be used to enhance, expand, or strengthen home and community-based services beyond what is available under the Medicaid program. Centers for Medicare and Medicaid Services, also known as CMS, shared guidance with the states in May, and we were made aware of the potential opportunity to use this funding for private duty nursing. Our team went through each recommendation using the parameters given by CMS to develop the pediatric shift nursing proposals. On June 14th, the department submitted Pennsylvania's proposed spending plan to CMS. We are currently waiting to hear feedback from CMS, and you can view the entire spending plan at the link provided on the slide. Next slide, please. While a significant amount of work has been accomplished over the past year, we realize we are on our journey of ongoing collaboration to improve Pennsylvania's pediatric shift care nursing model to better serve patients, families, home health care workers, and managed care organizations. We will continue to work through the recommendation in phases, and as the implementation of recommendations continues, we anticipate following up with the work group members and other interested stakeholders to provide expertise and feedback on our implementation plans. Please feel free to reach out to the OMAC Pediatric Shift Care resource account. We are happy to hear your input. Thank you all for listening, and I'm going to turn the presentation back over to you, Megan.
Thanks so much, Nicole. I also want to say a quick welcome to Gwen Zander, who joined us. Gwen is the Chief of Staff of the Office of Medical Assistance Programming and has been a part of this Shift Care initiative that OMAP launched, as I said, in 2019 since the beginning. So thanks for joining us, Gwen. I know I want to be very respectful of your time, Nicole and Gwen. If any of the participants have any questions, please feel free to use the chat. I did want to just, say thank you to the department. It's been a strange year and a half, and the Office of Medical Assistance Programming launched this initiative in 2019 to wrap up in 2020. And obviously things got a little hairy there in part of 2020, but I have to give credit to the department because, they really did a strong pivot and continued the work and allowed those of us who were participating in that to stay focused on that goal and the work. We had so much momentum and we didn't want to lose it. And with the support of the department, we did not lose that momentum and we got to continue through to these recommendations, everyone saw right now. Now, of course, this is pretty focused on the pediatric shift population, but what I always like to remind everyone is that the nursing workforce is the nursing workforce. That's one pool. So surely some of the nurses swim over to the pediatric side and some of the nurses swim over to the adult side and some of them swim back and forth. I like to remember that progress that ODP is making ultimately can trickle over to the pediatric side. Progress that OMAP is making ultimately will trickle over to OLTL. So when we're making progress around shift nursing and around home and community-based services in general, we're making progress for all. Nicole and Gwen, one of the things that, one of the things that we were pleased to see was that in this American Rescue Plan funding, which we know is temporary funding, it's a 10% increase in the home and community-based services that's allotted to DHS, and it has to be focused on home and community-based services. That was my real quick explanation of what that is for the folks who may not know. Some of the feedback we got as an organization was, wow, congratulations. We haven't often seen nursing specifically talked about in plans for funding like this. So can you talk a little bit about how that focus came about and why the shift nursing is, maybe why shift nursing is such a focus for the department right now?
Sure, Nicole, if you want me to take this one, I'll gladly answer. So thanks, Megan, for having me and for the welcome. I think that basically when we got the information from CMS, from the federal government, telling us what types of services would be eligible for this enhanced federal funding match rate, we had to kind of look at those categories, and we were driven by the categories that were laid out specifically in the federal legislation. One of those areas was private duty nursing. And so when we saw that included in the list of services that we could consider, we were really excited because we were, just kind of on the tails of completing this white paper and considering the different recommendations and thinking about, how were we going to fund the different recommendations that came out of the white paper. And so we were just really excited, and I think grateful for the fact that we were in such a strong position to put together and put forward some proposals so quickly that we knew had good stakeholder consensus and buy-in, because over a year and a half we engaged with 100 different people from all sides of this issue, and so we felt really confident that the initiatives that we put forward related to private duty shift nursing, particularly pediatric nursing, were going to be well supported, and we really believe they're going to have an impact. This is an area where there's room for improvement, and we're excited to be able to see whether these new initiatives make some kind of measurable difference in the coverage of nursing for these kids and these families. So it's a real commitment of the Deputy Secretary, Sally Kozak. And so we're, under her leadership, this has been a big focus for her entire time as deputy, but particularly now with all of this additional federal funding on the table.
Thanks, Gwen. We do have a question from Janelle in the participants, one of our participants, Janelle. The question is, how can we access the American Rescue Plan 2021 to assist us for funding for training the shift nurses for more highly skilled needs of the patients?
So there were several different aspects of a proposal that we put forward to CMS. We needed to get CMS approval in order to use the funding the way that we proposed. And so as we await final CMS approval, we'll have to start thinking about how we are going to operationalize some of these initiatives and how to actually make the funding available to providers. And so, stay tuned. There's going to be a lot of news and a lot of communications coming out of the department in the near future with instructions basically for providers about how to access this funding and what purposes it can be used for.
Thanks, Gwen. And I know we only have you scheduled for another couple of minutes, so I just wanted to say, well, I wanted to ask one more thing. I know just on the consumer subcommittee call recently, we got to hear a little bit of an update. Can you just speak really quickly to, the timeline of this ARP funding and, what's happening and what maybe the holdups are?
Sure. So CMS has been reviewing all of the different proposals that came in from states. And so we are awaiting our final approval from CMS. They have, come back and asked for some additional clarifying information. We're going to prepare that for them and submit it to them. And then we'll be in a position, where we need to start operationalizing. So setting up perhaps grant programs and, or funneling dollars to the managed care organizations in a directed payment model where they will be instructed to, funnel the money to the providers. So operationally, we have a lot of work to do. As far as timeline, the dollars will be available for expenditure through March 2024. So we're really going to work hard to get this money flowing as quickly as we possibly can so that we can maximize the timeline that we have for providers to access these dollars. The amount of money, depends on the amount of expenditures that we've made in the specific categories. So the amount of money will not change based on when we get it out. It's just how much time there will be to expend it. So we're gonna work really diligently to get this out as quickly as we possibly can because there is such a significant need.
Thank you. Yes. There's a question in the chat about will there be any type of regulation on how nursing agencies can utilize this money? I think right now there's not a clear determination about exactly where the funding will be going. So that might be a question. And Natalie, I see that question, and I think I'm going to be able to talk to that a little bit in the next session. So I don't, Natalie, who asked the question, I don't want you to think we're not asking that one, but I think it will actually fit a little bit more to something I'm going to talk about in a few minutes. Gwen and Nicole, one last question, just, with the federal focus on home and community-based services right now, and the hope that there is some really substantial funding and legislation coming down the pipeline to support a care infrastructure, not just in Pennsylvania, but across the country. Can you just give us an idea of what the sense of the department is around that, or what the feeling of the department is around that?
Yeah, I think that you said earlier, Megan, the nursing pool is the nursing pool. There are only so many nurses. And they are doing all of the work that needs to be done by nurses across the country. And so, also seeing this question in the chat from Nancy, planning for recruitment of nurses, we understand that there is, I'll call it almost a desperate need to continue to build up the resourcing for nurses so that there are more nurses available to take on all of the different cases that need to be covered. You know, we're hearing in hospitals that things are pretty dire or pretty desperate in terms of staffing. And so we know that private duty nursing in home settings is not the only place where this is a problem. So we see a real need to invest in and attract, you know, qualified and committed people to this work, because there's a lot to be done and not nearly enough people to do it. So that's a big priority for us right now, is helping to attract people to the workforce.
And I'll just add one more thing. That's why we're very interested in working with the nursing schools. That's why we were so happy to get that letter out, and we're already getting some feedback. So we're very eager to see how we can partner with the schools to try to help.
That is wonderful. And that PA Families Need Nurses Now is also initiating a project to engage with nursing schools on how we can help on a user and a caregiver level to inform some of those practices and some of that expanded curricula. So we look forward to connecting with the department on that. So thank you both so much for being here. You know, I think over the last few years, we've seen so much coming out of the Office of Medical Assistance programming and outreach to the consumer and outreach to families, and we appreciate that expansion and that extension of the hand. And we really have appreciated this partnership, and you know, just working alongside of the two of you has been wonderful. Nicole, I'll just throw out there, Nicole's mother is a former, I think she's retired now, a former home health worker herself. So, you know, I think Nicole is a special champion for those of us who utilize this service because she watched her mom deliver it. So there are champions in the department for our families, don't worry. And Gwen and Nicole, have a wonderful day. Thank you so much for joining us.
Thank you.
Thank you.
So I want to just quickly take I want to take a quick break. I want to respect that everybody has been chugging their coffee, and you know, that we've been sitting here at our screens for quite a while. We are just about at time. We're running a few minutes behind, so I'm going to just give 5 minutes for everybody to shut off their video, mute, walk away from the screen, and you know, my time says 11:04, so maybe we'll give 6 minutes. So at 11:10, we'll come back to the screen, and I'll talk a little bit about programs and progress that have happened since the last summit. So enjoy a break. Welcome back, everybody. We'll just take another minute to make sure everybody gets back to their screens. We're excited to jump in to our next segment, which will be, as I mentioned, I will be giving some updates on some of the progress and programs that have been implemented since the summit, some of the work being done around this shift nursing crisis. And at 11:30, we will convene our panel, our PA professional leadership panel, which we're excited to bring together leaders from across government, legislature, nursing school leadership, agency leadership, to talk about ways that we can really start to create a caregiving infrastructure in Pennsylvania, unlike what we've seen before, and how we as a state are poised to do so and can be a leader in that transformation. Before we get into since the summit, Dana, if you don't mind going back to that slide for the one poll, I feel like as we all get back in, maybe we can do a quick poll to get everybody back at their keyboard and engaged and ready to communicate. So we have one poll launching right now. This one is, how interested are you in learning more about the federal legislation around home and community-based services and advocacy opportunities? Very interested. I already know some, but I would like to know more, or not very interested. Some folks may be very well versed on this at this point. And you know, there's certainly always new information coming out. We've got almost half of our respondents, or almost half of our audience responding. And it looks like, by and large, our audience is very interested in learning more about home and community-based services and advocacy opportunities. Good news, at 1:30, we have a presentation called Raising Voices. It will be after the lunch break at 1:30. We'll be joined by Stacy Staggs from Little Lobbyists and Laura Ness from Beata Hearts for Home to talk about this current federal legislation and how that impacts the services that we all depend on, or that we support folks who depend on. So we hope you'll join us at 1:30 to learn a bit more about just the legislation and the programs in place, and then you know, on a provider and an individual level, how to continue advocating for the folks who utilize these services. So moving on, we'll jump into Since the Summit. It's going to be a lot of me talking for a few minutes, so bear with me. There's so many things I think that moms and advocates in my position want to say, so I'm going to try to keep it streamlined, and the slides are going to try to do their best to do that for me. We'll do a quick poll here. Have you or a loved, sorry, we're going to launch one more poll. Have you or a loved one ever depended on the care of a licensed nurse in your home for several hours at a time, which is what we call shift nursing? Your options are yes, I myself have depended on in-home shift nursing. Yes, my loved one has depended on in-home nursing. Or no, I have not yet personally had someone in my life depend on in-home shift nursing. It looks like we have the larger portion of our audience has not personally had someone in their life depend on in-home shift nursing, while 33% have. And, you know, I find that wonderful. I think that, you know, personal experience makes things feel very important. And it's hard to understand a struggle when you haven't experienced it yourself. So to know that 65% of the population of our attendees are folks who haven't personally been impacted by the shift nursing shortage, but are here to learn about it and problem solve around it, is really heartening to a family like mine. to know that there are so many folks out there who may not be directly impacted, but want to see change and want to see better supports and want to see a stronger structure for care in Pennsylvania. So thank you again for being here. In our Since the Summit title slide, I want to point out a really fun fact. The image there, so since the last summit, the image there, obviously we have a new presidential administration. And that presidential administration, for the first time in my experience as a caregiver of a loved one who requires home and community-based services, and possibly for the first time in my lifetime, as Elena said, this is a once-in-a-generation opportunity. We have a presidential administration that is uniquely focused on recreating home and community-based services in an updated way. And in that image, that's our very own community. This is Victoria Farrell is our community coordinator at PA Families Need Nurses Now, and that is Victoria there with now President Joe Biden. When he came to Pennsylvania, Victoria had the really unique opportunity to have a sit down with him and to talk about the experiences that supporting her son, Cole, who's 5, and utilizes shift nursing to be able to stay home and live at home with his family and his doggies and to go to school with other kids from his area. She got to give him that very personal testimonial and talk about how that has impacted and changed their lives. And, I think it's the voices of Elena, it's the voices of Victoria, it's the voices of all of us who use and support these services that are making this impact and are the reason that the home and community-based services, home care workers, home health infrastructure is on the lips of the federal administration because it was put in their ears by people like us, by supporters like you. So, I just wanted to give a cool shout out to Victoria for her, the ongoing advocacy that she continues to engage in. You'll see a little bit more of Victoria later in the presentation as well. Shift care in Pennsylvania is ageless. I often talk about it from the perspective of pediatrics because that's my lived experience and that's the world I walk in with my son. It is an isolating experience. So, real quick, we do have some caregivers on and we have folks who support caregivers. Utilizing services like home and community-based services, particularly shift nursing, which has been incredibly hard to staff and has left many caregivers being their 24-hour care, medical and parental care for their loved one. It can be very isolating, it can be exhausting. We do, PA Families Need Nurses Now, host family caregiver support groups every first Tuesday and third Sunday of the month. You can go to our website, pafamiliesneednursesnow.org/events, to find out when the next one is. Or we also have a private caregiver group on Facebook where caregivers, share our unique but similar to each other's struggles and share resources and vent. And it's been very cathartic and supportive for very many of us across PA. So please do join us and please share that resource with the families that you support. Next slide. So I like to think I'm really relevant, and there's these ongoing memes that so how it started and how it's going. So I'm going to say, how it started. 2 years ago, we all came together to talk about this issue at the first nursing summit in the summer of 2019. How it started: pay parity issues. Nurses, home health nurses, are not compensated and valued in a parallel way to their healthcare industry peers in facilities and hospitals. Training needs. We've heard in the chat, we've heard throughout the session, there's some really significant needs for additional training from nursing school on throughout the field. There's a job stigma. There's a lack of understanding. There's a misunderstanding of what home health is. My son is very medically complex, and the work that his home health nurses do are it's complex, it's acute, it's critical, and it's ongoing. It's very different than what a hospital nurse or a facility nurse does, but it is just as important, and it's sometimes a bit more difficult. Caregiver burnout is something we talked about at that first summit. And, it's something that's ongoing, and we've been very fortunate to have created this organization and to have the ongoing, supportive Vision for Equality and Philly IDS to be a resource to families and caregivers. But the biggest resource is going to be that bolstering of home and community-based services and attending to the lack of workforce in the shift nursing world. So how's it going? That's the second part of every meme. Well, how it's going is pay parity issues, training needs, job stigma, caregiver burnout. It's in some ways it feels like we're in the same place that we were 2 years ago. And in fairness to all of us, who saw a worldwide pandemic coming our way? That certainly has put a damper on the progress that we wanted to make and that we could make. And I'm tongue in cheek a bit about the fact that we're still talking about the same issues 2 years later, and families are struggling even worse now because of COVID for home supports. But all of that aside, given what has gone on in the last couple of years, in the last year and a half, there is progress still being made. There is work being done. So I don't want anybody to feel like nobody's listening, nobody's doing anything, the work isn't there. The work is there, and we're working toward it. It feels exhausting to those of us living it. But the iron is really hotter than it's ever been, given the federal discussion around home and community-based services. So it's starting to feel like perhaps now was the time. Now's the time we were waiting for. So next slide. Some of the state level updates on work and progress that has been made, as you heard from Nicole and Glenn from Office of Medical Assistance Programming, the Shift Care Initiative project that they implemented in 2019 wrapped up, and the recommendations were made to DH leadership based on stakeholder input from across the state and from across the industry. So, caregivers, nursing agencies, MCO representatives, folks from the DHS departments all came together, sometimes twice a week or twice a month, to problem solve and try to create solutions toward at least on the pediatric side, the shift nursing issues, which, as we said before, it's the same pool of nurses. So if we're starting to make progress in one department, that will ultimately feed into other departments. So that, those recommendations were so strong and are so valued that we saw them represented in the ARP spending plan that Nicole gave us a brief update about. So the ARP spending plan includes home nursing solutions. And while that funding is temporary, this ongoing discussion about home and community-based services on a federal legislative level is what we need to make sure that whatever is implemented can be long-term and not acute. There is new information about a $5 rate increase for medical assistance. So, this is really more, again, addressed at the pediatric side, but for individuals served through a state plan, there was a recent Department of Human Services $5 rate increase for private duty nursing that will be initiated or implemented in January of 2022 for medical assistance non-waiver services. Now, what does that mean? For us, the details are still unclear. We're still learning a bit about it. And hopefully perhaps some of our panel members can speak to it when the panel begins. And I know, we have wonderful folks from the Pennsylvania Health Law Project participating today that may be able to answer questions about that when we open that up. But there's a $5 rate increase coming down the pipeline, and for private duty nursing on the pediatric side, these have happened in the past, so we are hopeful that it will be initiated in a way that's highly accountable. and in a way that is diligent in making sure that it impacts the workforce that provides the services. As many of you may have seen, there was a wonderful Philadelphia Inquirer article around the shift nursing crisis and how that eliminates the ability for medically complex patients to discharge from the hospital into the home care setting when they're ready. That article is linked here on the slides, which we will share after the event. And Victoria, if you could put the link to the article in the chat. If you haven't read this article, it's very comprehensive, and it gives a wonderful and unfortunately scary snapshot of what agencies, what nursing agencies, home health agencies have been struggling with when trying to transition babies and other children home from hospitals who are ready, medically ready to transfer home, but where the home health supports simply are not available. Agencies as large and as robust as Bayada report having to turn away 50% or more of new patients because they simply don't have the workforce to support them. The article gives a lot of great insight around that. What the article doesn't get into, and which I think is really important to remember, is that those delayed discharges come at a high cost. And I don't just mean to the stress on the family and the young person who deserves to be at home, who has the medically technological support, ventilators, central lines to be able to do that, but where the infrastructure of care has not caught up. So the workforce is not there to accommodate that happening and to make sure that that can happen in a safe and functional way. In a 2018 study, there was an average, 2018 study out of Minnesota, there was an average of 51.9 days per patient, essentially delayed discharge because home health services were not available. And ultimately, the hospital costs would have been avoided if those patients had been able to discharge home. And what I think folks may not realize is that the net costs there avoided are astronomical. So the net costs avoided in this particular study with this small sample, it would have been $4.95 million of spending avoided on hospital costs had 28 patients that had a delayed discharge be able to discharge home to a home care environment. So this becomes an issue when we don't have a home health workforce, when the infrastructure of care has not caught up to the medical technology and the supports that the systems that are in place have set up for us. It ends up costing a significant amount more financially, emotionally, developmentally, but financially, it ends up costing a significant amount more for patients to be trapped in the hospital, in ICUs, and even in long-term care facilities, rather than being supported in their home where they want to be and where their families want them to be. Next slide. So as we've said throughout this presentation, some federal level updates that are really encouraging is that the Biden administration is focusing on home and community-based services. And you've heard the words caregiving as infrastructure. You've heard the words human infrastructure. The American Jobs Plan, the Better Jobs, Better Care Plan, all incorporated funding and legislation around bolstering home and community-based services so that children aren't stuck in the hospital, so that 14,000 Pennsylvanians who are in the adult waiver system aren't stuck on a waiting list waiting for services. We can't forget that in Pennsylvania, while children with EPSDT services have access to a robust medical assistance network, the workforce isn't necessarily there to support that or provide it, but the access is there. There are adults, there are folks who've aged out of that pediatric system who are languishing on waiting lists, waiting for services. And this home and community-based services funding is what can end that and what can transform it so that hopefully here in Pennsylvania, we can be a leader and a beginner in in utilizing whatever is coming down the pipeline and be ready to transform and be an example to the rest of the country for how we can implement home and community-based services on a really robust and long-term level. One of the things, again, we're very proud of is that Pennsylvania families have had the opportunity to share their voice. Our own Victoria Farrell was recently invited to take part in a live stream with Senator Casey and some other legislators. And we'd like to share that video with you now so you can hear Victoria's input.
Victoria is here to share her family's experience with us. Thank you, Victoria. Welcome.
Thank you so much for having me this evening. I'd like to say thank you to you first, Elena, for this opportunity. It's a privilege as a family member to be able to be here this evening, to even be able to share our story, because so many times families like ours don't have the support that we need to be able to step away and use our voice to speak about these issues. I'd also like to express my deepest gratitude to Senators Casey and Duckworth and Congresswoman Dingell for their hard work and dedication to the Better Care, Better Jobs Act and their unwavering advocacy for the disability community. As Elena said, my name is Victoria and my son is Cole, who is 5. He's intelligent, hilarious, curious, full of life, and he thinks he's the first person in the world to have discovered Mario, Donkey Kong, and Sonic, and can't fathom how mommy possibly knows these things because I'm too old. As of today, he would tell you that when he grows up, he dreams of being Mario and a plumber and a nurse and a child life specialist. And I'm here today to talk to you about those dreams and the reason he is able to hope and plan for the future. And that's because of home and community-based services. Cole was born with mitochondrial disease. And while he's a bug expert and a budding astronomer, he also faces very difficult health challenges every single day. And because of the mitochondrial disease, he has intestinal failure and requires a special IV in his heart called a Broviac to deliver the nutrition and hydration he even needs to survive. He has tubes in his stomach and intestines. He lives with epilepsy, hypoglycemia, chronic kidney disease, hypogammaglobulinemia, and muscle weakness, just to name a few. He requires hospital-level care to tend to his medical needs, but thanks to home and community-based services like skilled nursing, he's able to receive that care at home with us and remain an active part of his community. Our nurses are the very keystone of our lives. Like Colin said, they become family. They provide skilled care for Cole day and night. They do continuous assessments, medical interventions, emergency care, medication administration, seizure care, infection control. The list could go on forever. They also attend all of his appointments. We have 30 specialists and 4 therapists, so we're pretty busy traveling to appointments, and they're there for all of them. They follow his therapy plans, track his goals, they interact and play with him. They help access his education for him in the way that any other 5-year-old could. Home care nurses are really just one example of how home care and healthcare are infrastructure. You know, they really bring skilled care of a hospital right into my home and into our community. And if hospitals are infrastructure, then hospital care at home is also infrastructure. It's the way the disability community is able to access the care that they need while remaining part of their community, which, as we've been talking about, is so important. In our home, our nurses make it possible for Cole to thrive, to attend events, and to take part in day-to-day activities like visiting the zoo or playing t-ball. And so many people take those things for granted. Home care nurses also don't have a button on a wall to push when Cole's having a seizure, you know, with a cavalry of specialists to run in to help attend to the emergency. They have to act as a respiratory therapist, a neurologist, and provide the care of 5 or 6 different people all by themselves. And you know what? They always do. And while home care nurses provide the services and care of an entire medical team solo, they're not compensated nearly at the level of their hospital or skilled facility peers. And they lack the support necessary to even be able to do their jobs. And as a society, we significantly undervalue the life-sustaining services that home care nurses provide that allow me to keep Cole at home. And there's a severe nationwide shortage of qualified home care nurses, which means families like mine are left without the help and care that we really desperately need. For example, just this month alone, I have 328 hours of the 528 hours he's authorized for that aren't staffed. That's 328 hours I'm left to try to provide the care of a skilled licensed nurse on my own. 328 hours, I'm his sole medical provider, night and day, with no breaks, no sleep, and no ability to provide anything other than medical care and ensure that he stays safe, which is of course my priority. But my story sadly isn't very unique. There are millions of families across this country who face the same or even worse challenges because there are many people who don't qualify for these services under current laws. And that's just a shame. You know, the nurses who provide this care are a unicorn all of their own. They have to be critical thinkers, quick on their feet, compassionate, flexible, willing to become part of our families and overlook the chaos of our daily lives, constantly learning and growing. And they work just as hard as their hospital counterparts and have an even greater responsibility load. Not only do they deserve our support because they are providing a service that keeps our families together, but they do so in a way that makes our communities more fulfilled and stronger because everyone is given the same access. For us, that looks like being able to take our first family vacation to the beach, seeing his first movie in theaters together, going on a play date with friends, getting to spend time together as a family and just be parents. And being completely honest, me being able to care for myself by going to my own doctor appointments or having a normal sleep schedule, what's that? And knowing he's safe and in the hands of someone who will care for and protect him and keep him safe. And honestly, the ripple effect of not being able to care for ourselves as caregivers not only impacts us as a family, but it becomes costly in a financial way. And when children like Cole have consistent home health care nurses, it means that it's possible to leave home, even with all of his medical equipment, medications, and therapies. It means driving with him or going to the park can be a safe activity because thanks to his nurses, we can stay ahead of crises, handle them as they come, and continue to allow him to do everything he loves. You know, what if he has a seizure while I'm driving or his blood sugar crashes? Thanks to these nurses, we stay ahead of all of that. Investing in home and community-based services is vital to our society as a whole. It means getting my loved one, and maybe someday your loved one, out of hospitals and facilities and keeping them home with us where they belong. It means keeping families together, strengthening bonds, keeping parents in the workforce, and giving everyone equal access to pursuing their passions and dreams. You know, Cole may never grow up to be Mario, but he definitely deserves to grow up and chase whatever dreams he has, just like everyone does. His medical issues will only hold him back if he can't access the care he needs to thrive. Home care and health care are infrastructure. They are the foundation that holds families and communities together and the bricks that community life is built on. They are not just a need, but they're definitely a right for all.
Thank you, Victoria. Thank you so much. That was so powerful. You're absolutely right. And you really bring it all together that we're here to support not just our family members, but supporting caregivers and supporting home workers, including home nurses. And that is so, so important. And so Victoria.
Thank you all for joining me and watching that video. Obviously, you know, I'm a big fan of Victoria. She's a close friend now and a colleague of mine. And you know, the way that Victoria is able to share her experiences as Cole's mother and as Cole's advocate is unique and special. And we're always so proud of her in the way that she advocates not just for Cole, but for all people with disabilities who want to live in their community, and the home health workers who support us and support our loved ones. She's a real champion for not just the families, but for the workforce. So thank you, Victoria, for not only being a part of our organization here at PA Families Need Nurses Now, but for always so consistently partnering with all of our orgs that we love so much, like Little Lobbyists and other advocacy groups. So without further ado, I'd like to move over to our leadership panel. We have a few folks logging on. I see some more faces coming up. We are very, very pleased to invite several of our panelists who we have worked with in the past, some who we are just meeting today, and we're very appreciative of them jumping in with us. We're bringing together, you know, leaders in government, legislature, workforce education, agency leadership, recruitment and retention, with potential solutions and strategies around transforming home health services here in Pennsylvania for people with disabilities across the state. So if you would, panelists, take a peek, if you can, at this slide. Just to try to keep a little bit of order, we have numbered everybody. we've given everybody a number of order that they can introduce themselves. So if you could just take a moment, 1 to 2 minutes to just introduce yourself and what your role is. You know what? Do we have Representative Hohenstein on the line yet? I think we're still waiting. So we're gonna come back to him last. We're gonna skip ahead to Moira. Moira, sorry to interrupt. It sounds like your audio is a little, it's coming through a little strange for us. It just sounds very high pitched and garbled. So we will just quickly, you're gonna work on that. And Dr. Jen Bellott, we are going to come over to you.
Good morning, everybody. I apologize for my background. It looks like, just everybody else's, Moira's background as well, but still working at home, at least partially. My name is Jen Bellott. I'm the Associate Dean of Academic Practice Integration at Jefferson College of Nursing in Philadelphia. We are what's regarded as a large college of nursing. We've been around for almost 130 years now. And every year, last year, we produced just over 600 graduates across all of our programs. So my job in the College of Nursing is to oversee everything that touches the academic environment and the clinical environment, whatever that may be, across all of our programs from undergraduate through graduate and doctoral level nursing. From a personal perspective, I have 4 children and 3 were involved in reverse mainstream pre-K program, not even pre-K, daycare, ever since they were babies programs. And just as a personal vocation, I wound up as the substitute nurse at that program when it still existed, and have had a passion for advocating for kids in the community. Whether it be foster kids, whether it be kids with heavy medical needs, et cetera. So one of the areas that we have been looking into at Jefferson out of my department is it's incredibly difficult for reasons far beyond this conference to place students for pediatrics in this area. Just there's a lot of competition and not a lot of providers. And so part of what I do is I pay very close attention to trending, and I have seen, both as a mother and a professional, that the future of pediatric care is not in acute care. It's wellness care, it's community care, it's home care, and it's outside of CHOP and St. Chris, and the inpatient environments that we're also accustomed to around here. So as a person and as a profession, I have been very motivated by the desire to place our students outside of traditional inpatient placements for their training. And I think the time for synergy with this and the time for cooperation is here. So I'm very motivated to work with this group, and I appreciate you bringing me here today.
Thank you so much. We're going to keep going in number order for now, and then we'll loop back around. So up next is Jeremy Yale.
I will do a quick mic check. Can everyone hear me? Great. Well, good morning, everyone, and thank you so much to PA Families Needing Nurses Now and Vision for Equality for inviting the Office of Developmental Programs to participate today. I bring a message of regrets from our Deputy Secretary, Kristen Ahrens, who was unable to join today. So within the Office of Developmental Programs, I have the honor of serving as the Bureau Director for Policy and Quality Management, which has kind of thrusted me deep into this issue, not only into the nursing crisis, but from a policy perspective within the office, and more broadly, as we've heard earlier, our colleagues in the Office of Medical Assistance Programs speaking, that this is not, this challenge that our system is facing is not unique to the Office of Developmental Programs. It really is a shared challenge for all of us. I'm really pleased by a lot of the cross systems work that has happened within DHS. We were a little slow to get organized, but I really feel like there is some fire underneath us and some momentum. So it's really kind of an exciting time to be working in this space. I was also kind of encouraged to hear earlier this morning, Elena Hung talk about how she is feeling energized and hopeful. When I hear family advocates talking about hope, that certainly gives us hope as well. So really interested in having this conversation and look forward to it. Thank you.
Thank you so much. Next up, we have Amy Matthew-Similar.
Hi, good morning, everyone. Thank you so much for having us. And it is also a pleasure to represent the Mayor's Office today at the Nursing Summit. And so as Megan said, my name is Amy Matthew-Similar, and I'm currently the Executive Director of the Mayor's Office for People with Disabilities for the City of Philadelphia. So this is an exciting time for all of us to come together to talk about it, but also start to really visualize what those next steps will be to create home care as part of the infrastructure for our state and our nation and for our loved ones as well. My role at the Mayor's Office is to oversee a few entities. So I oversee the Mayor's Commission for People with Disabilities. And we will be having a public meeting this week, and I'll be sure to drop the announcement in the chat for all of you Philadelphians to join us and meet our commissioners and help us create our priorities for the year coming forward. So hint, hint, home care should be one of those priorities, but we need to hear from you as a commission. I also oversee the Office of ADA Compliance, which for those of you that are unfamiliar, the City of Philadelphia completed their ADA compliance transition plan in 2020, and we are currently implementing that plan, which is exciting for our city and for our residents as we move forward as creating compliance and inclusion practices for all of our residents, especially today honoring the 31st anniversary of the ADA. And then lastly, I oversee our very valuable constituent services where we connect residents to what they need, whether that's information, resources, or connection. So I am very proud to represent the Mayor's Office today and look forward to hearing from all of you.
Thank you, Amy. Jerry.
Hi, my name is Jerry Wagner. Currently the Director of Regional Field Recruiting for Bayada Home Health Care. And first of all, I just want to say thank you so much, Megan, for inviting me, and Victoria for putting all this together. I've been listening all morning and just fantastic job so far. Really keying in, highlighting all the issues that we all face. So excited to be a part of this panel discussion. A little bit about my background. I've been in healthcare recruiting for about 8 years now with Bayada. I'm in Western Pennsylvania, actually Allegheny County. So I started my career for about the first 5 or 6 years, just actually doing field recruiting, hiring nurses for clients, Bayada clients in Western Pennsylvania. The last couple of years, I've transitioned to this regional role, so now kind of overseeing most of the recruiting for Bayada in Pennsylvania, specifically for our skilled nursing unit, which for us, that means adult and pediatric shift nursing. So those are the areas that I'm particularly familiar with and some of the issues we face there, which most of them have already been highlighted, but happy to discuss that in a little more detail.
Thanks, Jerry. We're going to move on to Barry. Hi, Barry.
Hi, good morning. Sound check, are you able to hear me?
You're good.
Okay, thank you. Good morning, everybody. My name is Barry Bowman, and I work in Harrisburg, and I'm the Managed Care Operations Chief within the Bureau of Managed Care Operations. And that is a bureau within the deputate of the Office of Medical Assistance Programs. It's the same office and same deputate of the earlier presenters, Nicole Harris and Gwen Zander this morning. So my primary function is to ensure agreement compliance and contract monitoring and oversight of the MCOs that provide all of the managed care organization benefits within the Medicaid system across the Commonwealth. We actively provide these services, and I have a staff of monitoring and compliance personnel that oversee the provision of these services and are often directly involved in problem cases with shift care, that sort of thing. Just a little bit about my history. I've been with this program, the Health Choices Managed Care Program, for over 23 years, and the large majority of that was spent in direct oversight of the MTOs. I'm very familiar with this service because the service has been a problematic service for that entire time. But I'd like to think that the initiatives you're seeing out of the Office of Medical Assistance Programs now under the leadership of Deputy Secretary Kozak is in at least no small part due to some hard conversations Deputy Secretary Kozak and I had when she arrived as the Medicaid Director for Pennsylvania. We were familiar with each other from our early days in Health Choices, and she was also very much involved in problems arising from shift care and the need for shift care in those early days. And I think she was a little shocked to see that a lot of those problems still existed, but also that I was putting a lot of pressure on recognizing this as a crisis and service provision that I feel is actually approaching critical mass in the not too distant future. So I'm very happy to be here today to discuss these services and the importance of these services, and also to act as an advocate from the Office of Medical Assistance Program.
Thank you so much for being here, Barry. We're going to circle back around to Moira.
How's my audio now? Good.
Perfect.
All right. Sorry about that. We have a new computer here and just getting used to it. Anyway, my name is Maura Kalida. I am the Chief of Staff to Representative Jess Benham, who represents the 36th District, which is South Pittsburgh and a couple of the smaller boroughs leading outside of that. Jess serves on Health, Aging, and Human Services committees. So this is very much up her alley and our alley as an office. We really do a lot of focused work. Her background is in bioethics, and she is, I should also say, the first openly autistic state representative in PA. So this is a area that we are very concerned about and want to support. And so I'm just here to fill you in, I guess, a little bit on what we're doing. Thanks.
That's wonderful. Thank you so much for joining us. We are still, Representative Hohenstein has sent us an email that he is running a little late. So we're going to move ahead and hopefully he'll be able to jump in and join us shortly. Panel, a lot has been said so far around, obviously, as Barry said, this sort of critical mass we're hitting in the home health care shortage, and then also around this unique federal focus we have in addressing home and community-based services. One of our goals today is to, marry that and take that, this momentum that we hopefully are engaging or embarking on as a nation, and poise Pennsylvania as a leader in that transformation to a more robust, long-term, sustainable level of home and community-based services that guarantees that each individual who deserves to be home and in their community has that opportunity to not just get there, but stay there. So I obviously, as I have said, my son is 7. He's trach vent dependent. He has a tube in his throat that helps him breathe. He has a ventilator that supports him overnight. He has progressed to the point where he doesn't need that during the day anymore. We're seeing wonderful progress from him. He doesn't stand or walk on his own. He is 7. He's starting to pull up. He's a very small guy, but he's got big goals. He's tube fed by a feeding tube, but for all intents and purposes, for what we know, he's cognitively typical. He learns at the same rate as his twin brother. He learns differently, and he accesses his environment differently, and that has certainly impacted the way he develops and his ability to develop. But all the progress that he's made as a young person, as a little boy, and all of the progress we've made as a family in supporting him has come from those home and community-based supports and those home health nurses and those home health agencies who have supported us along the way. Miles's nurses are not simply a nurse who come in and give him medicine. They do all of those things with him. They help him learn to stand. They help him become interested in food by mouth instead of just by his tube. They play with him. They engage with him. They make him practice his sight words. He's going into first grade in a inclusion classroom where he should be able to be. In education, I'm a former special education teacher. We talk about the least restrictive environment. That's a tenet of education. Putting children in their least restrictive environment. And I think if we think about that from a community level, our goal needs to be putting all individuals into the least restrictive environment. And for a great many individuals, that is at home with their families or somewhere in the community where they are supported and where they can live an everyday life that they want to. So with all of that in mind, we have this workforce crisis. We don't have new nurses coming into the field of home health. And the nurses that we do have coming into the field don't necessarily have the training or experience to maybe ready them for that unique environment. And I want to bounce off of what Office of Medical Assistance Programming said and start with you, Jennifer, as a representative of one of our really prestigious nursing programs here in Philadelphia. I was happy to hear OMAP saying that they're looking to engage with nurse training programs. And you and I have talked about, that need. So could you speak a little bit to, what you've seen so far in how nurse training programs can and can't attend to home health within their curricula, and how you might see that transforming?
Absolutely. So let me start with our undergraduates. So these are the nurses, these are the students who will become your entry-level nurses, your RNs. Our entry level at Jefferson is a bachelor's degree. So we would be graduating an RN at a bachelor's level. I will say it's interesting as kind of trends come through and policy changes over the years. What's old is new again in some sense. This is not a new story to any of you on the panel. This is not a new story to me, but this is a new story for the public. And I do have to give credit to the Inquirer for putting it out there earlier this summer. It's kind of a raise the flag and raise the issue. So one of the biggest barriers we have with engaging with home care, we have in the past, but just from a logistical standpoint, we typically send 8 students at a time to clinical for undergraduate. And imagine, opening your door to the nurse and 8 students, that's not going to happen. And we have a 1-to-8 student faculty ratio as well. So we have some tricky things in terms of budgeting and being able to set up the logistics of home care, but that doesn't mean it can't be done. And in particular, I think with some of our more advanced clinicals, when our students are learning to kind of follow their passion and follow what they're interested in, instead of what they have to do to learn this piece of nursing, I think this is possible. It's really simply going to take a partnership of creativity. And I welcome our industry counterparts to take our hand and lead through that. If there's one thing that my department does, I mentioned that it's this academic clinical relationship, which traditionally means the hospital we work with. But my background is public health, so my bias is clear that this is our future. And I think to push our students in this direction today is simply to be on top of the trends and this is where we're going to be in 10 years, 20 years, it's going to be a foregone conclusion. So I think it's simply a matter of being creative, getting the right network, the right people at the table. And I am absolutely ready. My boss, our fairly new dean at Jefferson, happens to be a PNP, pediatric NP. And so I know this is right up her alley as well. And I think we're engaged, but, forget Jefferson. Let's look at this as a whole. When I was a kid, I used to read this book, Curious George Goes to the Hospital, right? He broke his leg. He spent 3 days in the hospital. He went to surgery. That doesn't happen anymore. You go to the hospital when things are severe or unexpected. You rarely stay overnight or for more than 2 days. So we really have to reimagine how we're looking at pediatric nursing care. And I think, again, that Inquirer article was a good first way to raise the issue among the public. When I look at our graduate students, we have a small but mighty pediatric nurse practitioner, primary care nurse practitioner program. Same thing. I think it's all about empowering, and for our advanced practice nurses, removing a lot of barriers of scope of practice, which we have plenty in Pennsylvania, and really allowing these NPs to be independently entering homes, making diagnoses and changes to care plans as needed. And I think the field is ripe right now.
Thanks, Jen. I want to take something that you said and bring it over to Jerry. Jerry is joining us, as he said, from Beata, and he's a regional director of recruitment and retention. And as we have nurses leaving school, and I think some of the things, just to say, many of our home care population are served by LPNs as well as RNs. For the smaller schools, or for the schools that do the more LPN level training, their issues are the same. Their capacity is limited, and their ability to partner with home care agencies and with families to provide some level of preceptorship in the home care environment is tough. So getting creative around that is necessary. But Jerry, could you sort of see the Inquirer article did a great job of talking about, rates, the way, what we talked about a little bit earlier, the way we value and view home care workers, and the way we compensate them for the unique work that they do. Could you just talk a little bit about what's been helpful, but also what the struggle is on the provider end to catch some of those grads and catch some of those veteran nurses?
Yeah, I can take a stab at that. Yeah, and again, great information there, Jen. Thanks for sharing what Jefferson's doing, and I agree. One of the big challenges there is just the availability and the ability to scale when you are dependent on clients opening their home, which is invasive and intrusive. So it is a challenge, and we try to do a lot with SIM, and there's some technology out there that can kind of help to get these new graduates prepared. But while that may give some good training on the skills side, as I'm sure everyone knows, there's a skill to working in someone's home, and that's hard to prepare students for without actually having them in the home. To your specific question, I'm sorry, getting a little off topic there. So just talking a little bit about rates and retention, and some of the challenges we face there. Beata it's been a pretty big topic of ours, thinking about new graduates. How can we best accommodate them? And some of the challenges too have to do with the way reimbursement is set up. And obviously we don't want to send a brand new nurse into a home without adequate training, but every hour that you spend training a nurse is hour that you can't bill for. And with our retention crisis as well, if we spend 2-3 months training a nurse, all the while there are hospitals knocking on their door, offering, full-time work at a higher rate, because let's be honest, we can't always compete with what the hospitals can offer. It does make it a challenge, and not that it's impossible, but that's some of what we face, especially throughout the pandemic. We've seen it really get to an extreme level. And, for good reasons. We do need nurses to administer vaccines and providing care, in the nursing facilities. And I don't want to downplay it at all, but when we're giving out, or when we're competing against the vaccine clinics that are offering much higher pay for short-term work, that also kind of chips away at the retention. So fortunately, I think we're coming out of the worst of the pandemic, knock on wood. I always hate to say that, but I think those are some of the challenges we faced. Did that answer your question, Megan?
Yes. I think we said a little earlier, pay parity. There's just no competing with hospital and even facility rates at this time. For a nurse who's highly skilled and experienced, home care is an untenable situation sometimes. Again, patients are home and supported in the home, but when they do get sick or they get hospitalized, shift care is shift care. Those shifts are not there. So, and agencies can only bill for what they bill for. So, there are some unique, I think, contractual structures. And as you said, some sort of reimbursement, perhaps creativity that needs to be discussed. I also wonder, and perhaps, this is a Jen and a Jerry and our representatives. We've talked in the past about opportunities for nurses, in the way that we attract teachers to a field. That's also a high need field. I come from the lens of education, so I try to make these comparisons. As a teacher, you're eligible for loan forgiveness, for federal loan forgiveness if you teach in a high need field. You're offered a state-based teach grant if you teach in a high need field or a high need area. Are there ways we can explore things like that? And could that potentially bolster, at least in the meantime, we're hoping that we're restructuring from the ground up, the foundation of home health, caregiving infrastructure. But in the meantime, because policy and legislation can take a long time, in the meantime, are there more immediate things that we can do? And Jerry, maybe you can speak to how maybe appetitive that would be, those types of programs might be. And then perhaps Moira might be able to jump in and talk about on a state legislative level, how maybe something like that could transpire.
Yeah, I'm sorry, I missed, can you repeat that?
Yeah, no, sure. I was talking about other ways aside from compensation and benefits. We know that's a dire need. Are there some other structures in place, loan forgiveness programs, drawing people into the home care field for some certain level of time and commitment, with a payoff, with loan forgiveness, with grants for additional schooling, things along those lines? Are those things you could see attracting nurses to the home care field?
Yeah, I think that's realistic, especially because, and I could be wrong on this, but I do believe there are certain hospitals where, if you kind of raised in the hospital system, maybe in a CNA position or medical assistant, that hospital may kind of give a sponsorship or scholarship to go to school with a commitment to work afterwards. And again, I could be mistaken about that, but I feel like that exists and we're competing against that to some extent. So I think that's realistic. I mean, retention is always a challenge in home care for the things that we can't control, like you described, things like a client that goes into the hospital and they might be there for a few months, and meanwhile the nurse isn't receiving a check, and they need to be flexible, maybe to drive 30 minutes further away to go to another case. So I mean, there's so many obstacles that already exist just naturally because of retention, that I think anything we can do to counteract that and not add additional obstacles is going to be beneficial.
One thing I'd like to say too is that nationwide, nurse residencies have gained significant traction. And what a nurse residency is when you have a brand new grad who is employed by, let's say, Hospital A. Hospital A engages in a very tightly run program of curriculum for the first year. And it's not just orienting that new nurse to the environment, but it's also supporting them psychologically, helping them with professional development, all sorts of, retention focused curriculum. And that is something I think that non-acute care environments such as home care would be well poised to participate in as well. So there's many programs that already exist and the curriculum already exists. I think that we could, I don't know that we would necessarily need to replicate that, but we need to make it accessible to smaller non-acute care entities so that would be affordable. So you could bring on new grads, you could entice them with more than just a pay structure, with more than just a benefit structure, and say, hey, we have this 1-year program. This is going to really help you. This is going to push you into a position of leadership and clinical excellence. But, you also have to be able to afford to subscribe to these programs too, right? So I think it's looking at this not just as a recruitment, but as a longer mid-range to long-range support structure for your nurses as well.
Thanks, Jen. I want to take a quick moment to welcome Representative Joseph Hohenstein. And we'll do correct me if I'm wrong on your name.
No, you got it. You got it right. I actually want to weigh in on the conversation you were just having, and my apologies for being late. I'm a number of different meetings and some of them run over. So, and if you haven't already talked about the need for increasing Medicare and Medicaid reimbursement levels, that frankly is the first place to start. I think when we're talking about compensation for home health care. But these ideas that you have right now of giving effective, incentives for people to enter into this part of the field. I know, with family members who have gone to nursing, into nursing, and actually I have 2 very close family members who went in after they had already had other careers. So if you have people who are entering nursing, especially in a career change type of situation, you're going to find people who I think are motivated by other factors than pure economics, but you've got to be able to give them enough of the economic incentive. And I think the kinds of things you're talking about make sense. And I think they can be done both privately through hospitals and schools, because so many pretty much most nursing schools are connected directly to an individual hospital. But I also think that there's got to be a coming together of the private industry, which is largely smaller business people. A number of my constituents run fairly small, say 20 to 30 employee, mostly nurses, home healthcare agencies. And those folks are disconnected from the broader scope, and they're certainly disconnected from professional associations, and like any nursing association, like the PASNA, they're not really connected in with those folks. And so they don't have the ability to provide the kinds of marketing to encourage and entice people to come to do their work. And I think that's one thing is that when you have a business model in home care that is so tightly identified with smaller and sometimes even directly in particular types of communities, we've got to start actually reaching out to some of those communities. And some of them are minority-owned businesses, some of them are women-owned businesses, and we've got to find ways to support those smaller businesses to then be able to be equipped to handle providing this increased level of compensation. because you're right, that's what you get. That's how you're going to have retention, or even people getting attracted to it in the first place. But I do think there's some opportunities there, and the types of programs you're talking about are the kinds that we ought to be supporting and continue to develop.
Thank you. Moira, I just wanted to give you the opportunity if there was anything you wanted to add there.
Yeah, no, Rep. Hohenstein covered a lot of what we can do legislatively. I think that increase, and just for us, the importance of compensating people for the work they do at an amount that is livable and fair is really important on, and work that we have been doing in the last 7 months that we've been here. But I mean, another issue that I think we could touch on a little bit is right now trying to achieve those things in our current state legislature is nearly impossible. The support doesn't come, I can say it, the support doesn't come from the other side of the aisle, right? And anything like loan forgiveness or raising a wage, there's always a fiscal eye to it, which of course we are conscious of, and these are taxpayer dollars. But at the same time, we see investment in people as, investment in the economy, investment in, well-being and health in general, when you're not having to worry about, how you're going to make ends meet, or, what you have to do, and or how many shifts you have to work, whatever that is. So the expansion of the reimbursements is really important, but right now, what we ask and what we need is more support from people like you on the ground, talking to our representatives who don't share those same views, and making sure that everybody understands the importance of our role here in state government. So, thanks.
Thank you so much for that. I think, again, to plug our own program, 1:30, we'll be talking, we'll have an info session called Raising Voices, and we will be talking about advocacy, not just on an individual level, but on a provider level. And I think, making sure that the experiences of all of these stakeholders is really powerful. So you're right, those economic impacts, not only on the families and the folks who are trying to stay in the community, but how that impacts small businesses, how that impacts large businesses, how it impacts the way they're able to do business. Home health is such a unique animal. So we know that it is, the service is comparable to that of what people are getting at a hospital and a facility now, but the way it's delivered is so unique that we really have to be careful about how we legislate around that and how we advocate around that, and being mindful of how unique that structure is, and the unique barriers that are in place for all the things that seem like a natural idea, but there's so much nuance in home care. Jerry, I think you and I were using that word a lot the other day. Nuance. There's so much nuance in home health, including and up to the different populations that are served and the different systems that serve those individuals, and how that impacts different people in different ways. So, my family is impacted by the pediatric side. The aging community is a really important factor here. We have one of the largest populations of people becoming elderly in a generation. So we have to be able to support those folks when they want to live at home with their loved one. The New York Times just did another article. New York Times did an article about a family basically like mine a few weeks ago, or in June, talking about the home health crisis and how that has made caregivers, families, parents, the one-to-one skilled nurse that's not available from the workforce 24/7. And the New York Times just did another article yesterday, day before, I lose track of days, around home health aid level care being impossible to staff at this point, and families who have loved ones, husbands, wives, mothers, fathers, who they want to keep at home and who want to be in the community, and the difficulty in supporting them there. So this is such a unique field. And, we're really lucky that we have two representatives here. We have Jeremy Yale, who's from Office of Developmental Programming, and we have Barry Bowman, who really represents more of the Office of Medical Assistance Programming side of things. I want to take a moment to give Jeremy the opportunity Jeremy, historically, my understanding, I've been walking in this world for 7 years with my son. My understanding is that there hasn't always been sort of an interagency partnership sort of happening under the DHS umbrella. Whereas in my experience in working with the department, that is what I'm seeing. Can you speak a little bit about, and you and maybe Barry can both talk about this. Most of our families are serviced in some way under the DHS umbrella. How are the departments within DHS working together and communicating and supporting each other to be on the forefront of transforming what home health is? Jeremy, I'll have you go first.
Sure. Thanks, Megan. I hopefully will set it up and Barry can knock it down. You're absolutely right. I mean, in government, we oftentimes use the term silos. And I think this particular need within the human services spectrum has been so complex. I think we've had a few people willing to kind of take and tackle this challenge. I know last year Nancy Thaler presented, and Nancy has really been spearheading this on behalf of the department, and has made some just incredible inroads. It really does today. It feels like we have a team, literally and figuratively. So we do have a transition home team that is made up of our cross offices. So it's not just the Office of Developmental Programs, the Office of Mental Health and Substance Abuse Services participates, Barry and his team at OMAP. So it really is a nice kind of cross systems approach. In addition, within our office, we have a statewide coordinator, Heidi Arva. So maybe some of you participating today have had the opportunity to meet with Heidi. She is, again, kind of another kind of a representation of our commitment to addressing these needs for families and individuals. In addition, we have hired a family coordinator, and this was a really exciting step. So before, Megan, when you were taking a look at past tasks and topics and then comparing them today, right, it feels like we're in a very similar spot. And I agree, COVID-19 really has put us back in this space. But there are some things to be excited and hopeful about. And I think the hiring of Jennifer Harmon Kringle is one of those things. So Jennifer is our family facilitator. Hopefully, those of you that are interested in this space, if you haven't had the opportunity to meet Jen, hopefully you will. But she's really been instrumental in working with families and engaging families around plans to transition from hospital or other congregate settings. And then more broadly, she is also that systems navigator and really helping to bridge between facilities and hospitals and physicians and managed care organizations and children and youth and county IDA programs and managed care organizations and right as we start to name some of these systems infrastructure, right, back to an earlier point, this is a complex topic. So Jen is really a critical part of that infrastructure. A few other things that we're doing to support these efforts. We know that at kind of the entry point into service delivery, case management is oftentimes very important and helpful for families. Back to that navigation piece and trying to find resources and funding and translating what a waiver is and all of these kind of things. One of the action items that we've taken was to expand Medicaid's targeted service management plan, which relates back to our state plan. And this now gives children the opportunity to receive case management and more specifically, really help with being identified at the county level and then having someone that is skilled to complete the priority of urgency of needs for services, which translates into the waiting list for individuals to get onto an ODP related waiver. So these are some pretty exciting inroads. We're currently working on a bulletin for supporting the referral process to county programs that will help inform families and individuals, and certainly provide guidance to our shared stakeholders across those other offices. But I don't want to monopolize the time here. I do want to give Barry an opportunity to jump in.
Thank you, Jeremy. And I think Jeremy spoke really well there about all the things that are taking place at that level. A lot of my familiarity with this problem comes from the pediatric community, because we oversee the provision of EPSDT related services. So while the accusation that there's often a lot of siloing within bureaucracy is true, I mean, there has been a fair amount of historic coordination for children who receive these services, and then as they matriculate into, as they age out of them, matriculate into other waivers or other programs within medical assistance. So we actually have been tracking folks on the day they turn 18, our shift care population, and we have a special needs unit that identifies them on their 18th birthday and then works with them over the next 3 years prior to their 21st birthday, when they will lose EPSDT coverage, to transition them hopefully into a waiver that fits their needs or one of the other medical assistance programs. So we've had that coordination with Jeremy's department and the Office of Long-Term Living and the various other entities within DHS for a fair many years. But one thing that is true is I think we're working a lot closely with our other partners within DHS now in terms of thinking more out of the box about these problems as we move forward. Just the topics of today's discussion, better communication in DHS isn't going to produce 1,000 new nurses interested in providing home care, in the next couple of months. So we're improving at that level, but there's still the overriding problem that's going to be very difficult to solve. But one of the ways I think we can get to that is sort of these investigations of things that we might not have looked at before. Jeremy talked about the importance of case management. And that's really been an emphasis of our deputy secretary over the last year and a half in terms of what we're overseeing at the MCOs and what we're sort of enforcing at the MCOs. We want to see more hands-on case management, particularly of this population by the MCOs. I think in the past, what we've seen is a lot of sort of telephonic case management of these individuals that didn't involve a lot of familial interaction and that sort of thing. And in some cases, when you get into a problem case where they're missing a lot of authorized shifts and there was a little knowledge by the case manager of what was really causing that, you would hear 4 or 5 different symptoms, but they often didn't have the really in-depth conversations with the family and the provider and perhaps the home health agency of what was really causing that. So over the last year and a half, we've been emphasizing oversight of the MTO case management programs. We have a special needs division within Bureau of Managed Care Operations that's been doing in-depth studies of problem cases and what the case management looks like in those cases. We've been offering sort of ideas for improvement, but also holding them accountable to Case Management Association of America standards and those sorts of things. So I agree. I think case management at both levels, with the managed care organizations, as these folks are receiving EPSDT services into the future, whatever program they may matriculate into, is very, very important. And it will also, I think, through better case management, start to identify some of the problems that might not just be say a nursing shortage problem. Is there a real problem within the home that's behavioral health oriented and they're not getting the best behavioral health supports, whether that be for the patient or family members? Those are things you can discover through case management that might actually help improve coverage of hours that aren't just due to a nursing shortage. Why is a family going through 17 nurses in a 4-month period? You need to take a close look at what's happening there. So, these are a few things that the department's working on. We're working on a lot of things, as we all know, because we're on this meeting today. This is not an easy problem to solve. It's not a Pennsylvania specific problem. This is a national problem. And I think if you travel around, if you go out and sort of Google what's going on in other states, I think a lot of states have been reluctant to speak about this, particularly from the government level, because it's it's technically a loser form. You really don't want to advertise, the difficulties your programs are having with these services. Sometimes it's a fear of litigation or whatever things that might result from that. But if you go out, I've tried to get good information or better information from a lot of states over the years. And it's not that they wouldn't share it. There's just not a lot of great information out there because I think they're all in the same position that Pennsylvania's experienced. This is a very, very difficult problem to address. So, but I will say this, there is some optimism, at least from my perspective. I think we have a really good administration who's concentrating in this. I have really good leadership in OMAP. I don't know if you could have a better leader in OMAP because she is a nurse. She did provide these services, and she also has a history of seeing these problems within the Medicaid program. And she tends to think out of the box, and she'll make decisions, and she'll make hard decisions. So I think we have really good leadership here. I think ODP has great leadership. And as your keynote speaker spoke, I think you have at this point a Washington that's open to listening to these problems. And if you can lobby and advocate hard enough and sort of get this on a better level of discussion and not just, give Medicaid more money, really put a human face on this and what the results are. I think there's some opportunities for improvement here that might go a long way to helping. It's not going to solve the problems, but maybe improve things.
Thank you, Barry. I agree. I think it's one of the things that we have to focus on, and why I think, I sound a little Pollyanna, but I consistently message out that I think Pennsylvania is so unique in the way we do things here. At least on the pediatric side, many children with disabilities in Pennsylvania have access to a robust system of medical assistance that in other states are maybe not so easily accessible to families like mine. So we have less of an, at least in this population, we have less of an access issue, but we're still struggling to get that provider support. And that's not necessarily something that, that is built into the system organically right now, because again, the history of home health is very different from what the present and the future of home health look like. So I think there's so much restructuring that has to happen. But we do right now, we have leadership within DHS that's very focused. As you mentioned, OMAP's Deputy Secretary Sally Kozak is a former nurse herself. We have DHS leadership. Teresa Miller moved on and Meg Sneed has moved in, and they both seem to have a very high, work in the spirit of really encompassing social determinants of health across disabilities, across race, across socioeconomic status, and making sure that those are factored in to any solutions that we're creating. And this cross-agency, interagency support for each other under the DHS umbrella is something unique that I think that both of them have fostered, and that the teams at DHS seem to be engaging in a really robust way right now. And then we have a governor that's very supportive of home and community-based services and very supportive of deinstitutionalization. And we have Senator Casey, Pennsylvania, who is championing these home and community-based services on a federal level. So man, aren't we the ones to watch, Pennsylvania? We're uniquely poised to be the transformation that we want to see. So, Barry and Jeremy, just to sort of keep it on you for a little while. What do you say to families, providers? How can we engage the department? What should we be looking for from the department? How can we continue to inform the way that the department is working and holding all the systems accountable? What are the mechanisms we can put into place so that the voices are back and forth ongoing?
Yeah, I think that's a great question, Megan. I think for starters, you're doing it right by raising awareness with the summit, by keeping the pressure up as you should with lobbying activities and keeping those lines of communication open at all levels of government, right? And you kind of work from the bottom up there, but back right through the governor's office, through our secretary's office, and then through individual offices. That really is critically important. I can't help finding your stories just so compelling. You talking about your son and his needs, Victoria talking about Cole and his needs. I think you walk the walk, and when you bring those stories to us to share and to have a deeper appreciation and understanding of what it's like to walk in your shoes, that helps us to move our policies forward as well.
So not to cut, sorry, Barry, not to cut off. I just, Moira and Representative Hohenstein and Amy, we haven't gotten a chance to hear from Amy, and there's so much I know that I want her to say that I would love to engage her in. As legislative bodies, as elected officials or representatives of elected officials, what are the ways that you can see? Let me back up just for a second. Jeremy, I was so appreciative that you used the word infrastructure. You were talking about the departments, you were talking about the services that they provide, and you used the word infrastructure because realistically, that's what home health is. It's a portion of infrastructure that supports people with disabilities in accessing the physical infrastructure. I think I read a recent Forbes article that talked about the notion that caregiving is not infrastructure, defining infrastructure as a general term for physical systems, such as transportation systems, roads, communication, utilities. But in order for all individuals to utilize those systems and utilize those who deserve to live in a full life in the community, we have to understand that the care workers are the basic physical system providing the access to those actual physical systems. So they are, by way of extension, they are infrastructure. We once had dirt roads, we now have superhighways, and where we once had 2 trolleys, we have entire subway systems. And those were updated ideas of infrastructure that provided expanded access to the community for some individuals. And I think it's, it may be hard if you don't have limited access to that to understand, to recognize that caregiving is infrastructure, but caregivers are the bridge to the community for people with disabilities. They are the bridge. So Representative Hohenstein, Moira, and Amy, if you could just each sort of take a turn in how do we best continue this conversation and sort of turn minds and turn hearts and build a foundation of infrastructure in Pennsylvania on a legislative level.
If you've invited me to speak first, I'll go ahead quickly. A couple of folks have talked about the value of what we do and what you just were talking about. We have a lot of folks, and in particular from the other side of the political spectrum of where I am, who have a certain nostalgia. And so what's the nostalgia? The nostalgia is, oh, we used to get doctors coming and doing home, house calls, and we had the doctor's office right there in the neighborhood. And our current structures, frankly, have eliminated that. But traditionally, that was an extremely valued position. It was an extremely valued service for the community. And what people, I think, fail to recognize, and maybe perhaps it's because the doctors of yesteryear were predominantly white men, and the nurses of today are most often women and most often people of color. We value the services they provide differently, and we value them individually differently, even though on a technical level, the nurse of today is far superior in skills and in access to providing the kind of care that people need than the doctor of yesteryear. And I think we've got to be able to make that clear to people that the traditional concepts that we have that are rooted again in race and gender and economic, you know, about the value of services that allow people to live their best lives, whether it's a child with a disability, whether it's an elderly person, whether it's someone who has become disabled in the process of an accident or anything else. I think what we have to get people to recognize is have that direct identification with both the consumers, the patients, the people, and their families, and also have real direct identification with the care providers. And we've got to make everyone in that be able to have their human stories told, and not in a way of pity or of oh, we're doing you a favor. No, it's we are we are providing to you that which you deserve so that you can provide to us your gifts and your contributions to our society. And that's the narrative shift. It has to go from a charitable, we're, the folks giving you this, the crumbs that come down from, from heaven, to no, you are on an equal space with all the rest of us, whether you're a poor, impoverished kid in a, who needs special education services, or you're someone who has, through her own sheer force of will, after having, gone through a different career, gotten yourself into nursing and said, this is what I want to do because this is where people get helped. Whatever it is, we've got to say, we see you, we value you, and we're ready to have you be part of our whole community. And frankly, even the word infrastructure, while you're accurate, we need more humanizing words than that. But I do think that is an important place where, at least at the presidential level, we're beginning to hear some of those things change. So that's my 2 cents. And I know you have to hear from the other folks as well, from Moira and.
Yeah, I can jump in. I think for our office in particular, and I think this kind of is what the rep's saying, but in a different way, but we look at everything through a disability justice point of view. We want to make sure, one of the things Rep Benham always says is that I'm not disabled. I'm disabled by the way that my community has been built around me, right? And so bringing that infrastructure, as we're calling it, and making it the normalization across the board. If we make things accessible for one person, it'll be accessible for everybody else too. But this has to be in the forefront of our mind when we're passing legislation, when we're advocating, when we're doing that. And also part of that is allowing the people themselves that have been labeled disabled by our society to speak for themselves, the self-advocacy of that, and really that the way that we can relate to people. Sometimes it's, we don't want to be gatekeepers. We don't want to block. We think that the most important story comes from the impacted person, right? So I think in your role of advocacy and, trying to move legislation is just remembering that part of it and making sure that we're focused as legislators and as legislative office on providing on whatever we do, making sure that disability justice is reflected in that work, and moving forward from there.
Thanks, Moira. I do want to say before, because I think it sometimes gets away from us, one of the voices that we often miss here is the home health workers themselves, because they are all taking on too many shifts, or they're taking on as many shifts as they can because families like mine need them so desperately. So when we're talking about the folks who are impacted, and the self-advocates and the family advocates, we need to also really remember that there needs to be the worker advocate, So these are highly skilled, highly necessary professionals who are creating equitable access to a community by way of the work that they do. And as we've all said, they have to be compensated accordingly. So I think, obviously always focusing on that and keeping in the back of our mind, we know that funding is the devil that it is. And we know that legislation is the devil that it is. But in all these ways that you've all said, transforming the way we view home health care, transforming the way we understand what that is now, transforming the way we value that as a society and as a financial component is going to be, paramount to anything at this point to fix this issue, particularly around home health nursing. So I want to bring Amy Millar into the conversation. Amy, I'm a Philadelphian, so Philly is my personal focus. I was born and raised here, and I live here and I utilize the services here. I think we're so fortunate to have you in the role that you're in right now. And Philadelphia it's a beast. We have some of the most affluent people in Pennsylvania, and we have some of the least affluent people in Pennsylvania. We are the opioid center of the country. We are, we sort of represent everyone here. And, disability doesn't discriminate. Disability hits every portion of those populations across other social determinants of health. So as you hear us talk about home health nursing and knowing that you encompass this entire disability population and the people you support in a city as unique and robust as Philadelphia in its population and its demographics, what do you envision? What should we be focusing on? We're restructuring Pennsylvania. What are our goals? What are our focuses?
Thanks, Megan. And again, it's been great to just listen to a lot of our leaders here today. And I think one thing for myself in our office is listening to who's not here and in how accessible is it for families and workers and individuals to have access to even those of us on the panel. Are our websites accessible? Is there a way for people without technology to connect with us, to share their stories? How many families right now are not even able to attend the summit because they're right now at camp providing nursing care to their child because that shift wasn't covered by the agency? Or for the family that's in the hospital and dealing with, this summer season, as we all know, it's referred to as baby doctor season, right? So lots of new residents, new staff, which is great. We want to see these new folks coming into the field, but it also continues to burden families that then have to feel that they're constantly fighting or advocating for their loved one, or that just the mere fact that we have to start looking at caregivers as also valuable members of the team, and that they do know what they're talking about, and they need to be given that rightful respect and placement at the table. And for myself, I feel you're right, Megan. It's a very unique city with a lot of unique needs, and there is no one approach that's going to work for our city or the members of our disability community, no matter what we do, because it has to be as diverse as the population we're trying to serve. And so I think as leaders are working to redesign structures, is that they have to have the lens of access at the beginning, because if we don't get it right from that point of view, we're going to have so many missed opportunities, that if people don't know how to find their representative, how can they engage their representative? All the representatives and senators and leaders that are not on the call, that are not engaged on this topic, how do we get them engaged? I think is vital questions as we go forward. I want to see family caregivers be moms and dads and siblings and grandparents and aunts and uncles. I want to see individuals be students and athletes and employed and falling in love. I think about today particularly, it's so wonderful for us to have this opportunity on the anniversary of the ADA, but we have so much work to do. Two people receiving services could not get married right now and still maintain the same level of benefits. They could lose their nursing just because they fell in love. And I want to see a Commonwealth, a city that is truly not only equitable for all, but that we have the same opportunities as everyone else. And that's my hope, is that, yes, it's wonderful for us to have summits like this and bring leaders and talk about it. But so oftentimes what families really need, we put in the parking lot, right? And it never gets out of there. And we have to bring families out of parking lots. They have to be at the table. And you know that this is a favorite saying of mine, it's nothing about us without us. And I think that that has to be true of those that utilize nursing, the individual, the family. No legislator should be putting forth a bill that addresses this crisis without the input of those that rely on nursing and their families. And same for our office. We are working to ensure that whatever we put forward has had the input and the collaboration of diverse Philadelphians so that we can meet their needs in a diverse and equitable way.
Thank you so much, Amy. So we are at 12:47. Well, that's what my laptop is a little behind. We're at 12:52 according to Apple. And that gives us about 8 minutes until the break to open this up. You know, I've been trying to incorporate some of the questions that have been coming through on the chat from folks. I thank you all for being on this panel and for engaging in this conversation. I wanted to continue that sort of flow of where we were going before we brought in some of the maybe more specific questions from the crowd. But I do want to honor what the attendees are asking. One of the questions that came through, and you know, we may have to figure out who's best to attend to this. It may be Jerry, it may be Barry. Right now, families who utilize shift nursing, pediatrics, adults, whomever you are, whichever system serves you, it is very likely that you need to use more than one nursing agency to staff your loved ones or your hours now. And that's what in the industry we call co-vending. So there's multiple vendors cooperating, ideally cooperating to provide the same care for the individual, but through disparate businesses. Oftentimes those relationships don't work out for one reason or another. The family and the agency aren't the right fit. The nurse and the agency aren't the right fit. The nurse is a wonderful fit for the family and the individual. The nurse is, you know, very well versed in this person's care, but they're no longer able to stay employed at that particular agency. Right now, there's a mechanism in place where nursing agencies can financially fine nurses for leaving one agency and moving to another if they want to continue care with a patient. But they no longer want to be employed with that particular agency for one reason or another. And that has posed problems for families in the past because nurses are so hard to find as it is. And when you have a complex individual who needs a unique level of care and is a unique person and can't always necessarily communicate and advocate for themselves, when you have somebody who's highly trained, not just in nursing skills, but in the skills for your particular individual, it is beneficial, not just beneficial, it is necessary for the continuity of care and for the ongoing health and safety of that patient for their nursing team to stay in place. So I don't, you know, perhaps Jerry and then maybe Barry could both speak to ways that we might address this I guess we call it the non-compete. Is there something families can do to mitigate some of that issue when that comes up?
Yeah, that's a really, really great question and probably not an easy issue to answer. And to be honest, I don't know as far as is there something we can do from like a lawmaking perspective? I don't know that I know the answer to that, but I guess I'll just present two sides of it to consider. And then I think there's a lot of, again, nuance, a lot of, a lot of specifics that could sway you one way or the other. But I think on one hand, you're looking at protecting an agency who is spending a lot of time and money recruiting and trying to retain their nurses and protecting them from losing their staff. And that's one side. And then the other side is, and this is something that when I was working in a service office, my director always kind of ingrained into me, but if you have a nurse who's working well with a family, the family loves the nurse, and the family does not want to stay with your company, then there's something that your company is doing wrong, most likely. So I feel like that's the other side of it. Why should a family have to lose their nurse just because if truly the company is doing something wrong, versus how do we protect companies so that they're not afraid to send their nurses to a home with multiple agencies with the fear of we could lose our nurse who we need. So I don't know the answer, but those are two sides of the coin maybe that I could present.
Thanks. Barry, do you have any thoughts around, oversight of an issue like this?
Yeah, I think it's difficult actually. Maybe for folks who don't understand necessarily how government works in the grand scheme of things. So I'm a regulatory officer, I'm a professional civil servant, so I don't legislate. So the things you're talking about there, sort of prohibiting non-compete clauses, which I've absolutely seen used, and I've seen it become problematic in certain cases over the years. We have no ability to sort of address that. As the Medicaid regulatory agency, we can't step in and sort of mandate to providers how to run their businesses. And even if we were to enter clauses like that within the health choices agreements for them to force down on their providers, I think before you go that route, you really need to understand what the end result of that's going to be. Is it simply going to be the removal of non-compete clauses, or is this going to cause a problem within that community, or the provision of services that you didn't? Unintended consequences are always a problem for sort of quick fix or knee-jerk sort of items. I will say this, that co-vending is, it's almost like a necessary evil, particularly when you're dealing with children that are highly fragile and have a lot of serious acute medical needs, because they often have high levels of authorization, high hour authorizations, well over 100 hours per week, that sort of thing. So they may have a nurse who needs to go out on maternity leave. Nurses or get sick themselves, or have to take care of a family member, and then you're sort of struggling if the existing agency can't cover all those hours. What do you do? Well, from the MCO's perspective, you're going to have to go out and find another agency that might be able to help, and then you run into all the things that you very adequately explained as we went into this. So I don't think there's a great easy answer through the non-compete clause, and co-vending I think is a necessary evil. But I think before you start investigating what sort of hammer techniques you're going to take to something like a non-compete clause, you need to fully understand that issue. So that's one of those things. Again, we're talking about everybody's input today. We would need to have everybody's input in that before we make some sort of decision about a fix that we might want to put in place.
Thank you. There's a lot of questions coming through about, people need staff. They need staff. They need their hours staffed. And I think we are, we're all feeling that crunch. Those of us who have loved ones who rely on in-home nursing. And I wish that there was one answer. I wish there was an answer for how we, how to better attract staff, even from a family level. That's why we're here today, because unfortunately the truth is that this is every family. This is every family. I like to make myself an example. The things we need to think about, and Amy talked about this a little bit as well, considering all the factors. My home is in a semi-suburban neighborhood. We have a lot of street parking. It feels very safe here. My son's room is a combination of a little boy's room and an ICU. We try to make sure that we're fortunate that my husband and I both work. I work when I can. We don't always have nursing. And, for 4 months, he was the overnight nurse 4 nights a week, and I was the day nurse 5 days a week. And we are just coming out of that fog now. But we are, we're kind of We live right near I-95 and we're very near Route 1. We are an ideal case. We are an ideal case. We are the easiest to staff. He is very high needs. Miles is very high needs and he's very complex. But from those other mitigating factors where it may feel like safety of the nurse is an issue or the work environment, because it is strange, home care, you know, the nurse isn't working and they're not walking into the same hospital or the same facility every day. They're walking into someone's home as their workplace. We are one of the ideal cases to try to staff in many ways, but it is difficult. And like I said, we just went 3 to 4 months where for 4 overnights a week, my husband stayed awake overnight. And for 5 days a week, I was the one-to-one nurse for my son, in addition to our other children and our work responsibilities and our other familial responsibilities. So I always worry if I can't get staffing for my son, and if the other moms and families similar to me can't get staffing for their children, what is happening for the families who don't speak English as a first language, who don't live in a house that has the space to accommodate a workplace? So just as we're thinking about solutions around this, I want to make sure we're always thinking not about the easy to staff cases like me, because I can't even get my son consistent staffing, but that we're thinking about all of these other social determinants, and that we're thinking about when we're building, when we're envisioning the way that we're going to transform home health. Like Amy said, we need to make access for everyone. We need to put that at the forefront, because planning backwards is never the easy way to do it. We're at time right now. I do want to give all of our attendees the time to take a good break so that they can come back and join us for 1:30. Any closing thoughts? If anybody really wanted to say something, please, unmute yourself and jump in. But overall, I just, on behalf of PA Families Need Nurses Now, on behalf of Vision for Equality, I want to thank you all for being part of this panel. And I really look forward to continuing to engage with all of you around solutions for all of the families like mine in PA.
Thank you, Megan.
Megan, thank you so much. And I hope that this leads not only to more conversations, but action, because that's what I think families really need, and what the staffing need and what the nurses need is we need tangible action, so that parents are not worried about how exhausted they are, that they feel unsafe to drive their child to a doctor's appointment, that moms and dads and siblings aren't at camp today missing this to provide nursing care, that moms that have 3 agencies to work for and still can't work or sleep or take care of themselves and their needs. We're losing far too many caregivers and individuals because of the lack of available nurses. So I hope that today will lead to more actions for everyone.
Thank you so much, Amy. Okay, we are going to see you in a little bit. We will take a break. It's 1:04 now, according to my iPhone, and we're going to come back at 1:30. I'll be back a few minutes before that, just to make sure anybody who's trying to get in, who's new, can get in. But I hope that you'll join us. Up next at 1:30 is our info session, Raising Voices, which will center around advocacy opportunities for individuals and providers, and where we can talk about how to make some of the things we've talked about today actionable. So thank you again, panelists. We appreciate your time, and we really appreciate your work going forward to make change.
Thank you.
Thank you.
Thank you.
Hi, everyone. We're just at 1:30. We'll take a minute or two to let people get back to their screens. But we're very eager and excited to get started with our next info session, Raising Voices, Advocacy Opportunities for Individuals and Providers. So we'll just, hi, Stacy, I see you're up and you're listed as a panelist now. So we'll just, let me just double check that we have Laura. Okay, and Laura is on as a panelist. Hi, Laura.
I'm here.
Hello. So we'll just give maybe one more minute to allow people to return to their screen and get settled back in and let their legs fall back to sleep. Just, you know, I forget how long I sit sometimes, and then I stand up and my body's not ready for it. So, okay, looks like we've got some people popping back on and re-entering the room too. So that's good news. Welcome back. Thank you for staying with us after that break. For those of you who are returning from the morning session, that went by pretty fast for me. I don't know about you guys. I wish we had days upon days to talk about these issues and to just work together towards solutions. So I think we're building a really good and continuing a really good conversation around this issue, honoring the fact that, nobody foresaw a pandemic coming our way, and that there are certainly some barriers and limitations to what progress could have been made in this time. But, and also honoring that's obviously that's no excuse, and individuals still need the care that they need at home, and they deserve the care that they need at home. So we still need to work toward these solutions one way or another. And action is what's going to get us there. And speaking of action and advocacy, one of the ways that we have seen the most action come out of legislation is through the work of self-advocates, family advocates, provider advocates. And we are really pleased today to have our two panelists here, our two presenters here. Stacy Staggs is the Director of Community Relations for Little Lobbyists. So she works alongside Elena Hung, who delivered our keynote address earlier. Again, a wonderful organization that we love partnering with and that we've been such a fan of and so thankful for the last 4 years. Today's the ADA's birthday, as Amy Millar mentioned, and this was the birthday week for Little Lobbyists. Little Lobbyists is 4 this year. So happy birthday, Little Lobbyists. And Laura Ness, joining us again. Last year, you joined us, and we are so grateful to have you back. Laura is the Director of Government Affairs for Beata Hearts for Home Care, which is a really unique arm of Beata that does advocacy work on a policy level and engaging, not only themselves, but their peers, other providers, and doing a lot to maintain the family voice in all of their work. So, I'm going to turn it over to Stacy first, so Stacy can give us a little bit of information about Little Lobbyists and then, the way that works.
Great, thank you, Megan. Can you all hear me? Good, okay, thank you. I want to start by, just saying how much I appreciate being part of this summit this year and able to have the opportunity to speak with you all. We are in such a different place than we were last year. And, there's really good momentum that's happening around home and community-based services, in-home healthcare. And just, I'm feeling a lot of hope that, I'll be honest, I was struggling with in recent years before now. So I want to, again, thank you for taking your time today to spend with us and for giving me this opportunity to be part of the conversation. There's already been such effective and wonderful discussion happening in the morning session. I'll do what I can to make this engaging and fun, maybe a joke or two. But I got to tell you all, I'm still reeling from Elena's keynote remarks. She is as wonderful as she appears. And I'm so grateful and thankful that fate and social media put us together, because prior to our meeting in 2017, I was not feeling very hopeful. I was definitely more worried. So I want to go back a little bit. I know Elena talked about the beginning of Little Lobbyists, and it really was two families watching the news, sitting at their kitchen table, completely unable to abide what they were witnessing when Congress was going through repeal efforts to the Affordable Care Act that would directly affect their children, my children, and I'm sure many of your kids. They have the proximity to the Capitol to be able to say, you know what, let's just go up there. What can they do? Maybe we'll find somebody who wants to meet with us. And I will say that our family advocates, our self advocates, the nurses that traveled with us to Capitol Hill, we're hard to ignore. We take up a lot of space. We're a conspicuous bunch. And then once we've got your attention, we're also hard to say no to. So we're leaning into that aspect of our advocacy. And after the first day, here's one of my daughters here. After the first day on the Hill, it was so successful. We were finding people in the cafeteria. We're talking to staffers in the elevator. And I remember talking to Elena early on and saying, I don't understand. How do you get appointments with senators? So you like a letter of introduction? How do these things work? And she goes, the doors are open. It's a public building. You don't even really have to knock. You just walk into the reception desk. And that audacity really embodies Elena and Little Lobbyists and what we're trying to do in our work to advocate for kids with complex medical needs and disabilities. We do focus in 3 ways on advocacy, education, and outreach. We agree, we know that we are stronger together, that our impact is broader when we're speaking in the similar voice, with the same goals and moving in the same direction. It has been a real labor of love over the last few years, and straight up stark fear and terror over what the previous administration was aiming to do with taking away the Affordable Care Act. I don't know if you guys have seen it. I haven't seen a replacement plan even at all. I guess that might be out the window. But thankfully, now we're not talking about protecting the Affordable Care Act. We're talking about expanding it and making it stronger and eventually getting us to a place of universal health care, because we know that healthcare is a human right and access to that is part of what makes this country great. We have work to do, but we've already accomplished so much. I do want to thank Megan for recognizing Little Lobbyist's 4th birthday. Like Elena, birthdays are not guaranteed. And I have twin girls, they're turning 8 this September, and that was not something we could have even hoped for when they were born prematurely at 28 weeks, immediately intubated and rushed to the neonatal intensive care unit. My pregnancy was going great until one day it wasn't. And when the doctor made the decision for us to go, to have the surgery, the emergency C-section, everybody flew into a very well orchestrated and highly trained code. Really, like they were moving quickly and successfully able to get us through the procedure, intubate the girls, get them to the neonatal intensive care unit, where they spent the next 98 and 110 days literally fighting for every breath. When we came home from the NICU, when we were first discharged from the hospital, we got the explanation of benefits and claims cost was over $1 million. So had the Affordable Care Act not been in place, my girls would have been uninsurable before their first birthday. I, again, recognize the benefit of the protections of the Affordable Care Act, all of the monumental changes that have come from that, in addition to knowing there's more work to be done. We still have issues with accepting the Medicaid expansion. I live in North Carolina, I should have mentioned. So thanks for letting me hop into your summit here in Pennsylvania. But North Carolina is one of 12 states that has yet to accept Medicaid expansion, and that is hurting us, especially in rural areas. We have lost hospital locations in North Carolina. I'm sure the same has happened in Pennsylvania. And more to the point for this group, the staffing issues, the worker shortage that we're seeing for home healthcare nurses is, it's really been exacerbated in the last year and a half. I, like many of you, have, gone without overnight nursing, gone without daytime nursing, trying to maintain a household, maintain work, maintain her twin sister, a relationship. I mean, I am married too, so there's that. And, trying to get all of these things done when you're really just in survival mode. I feel more hopeful now that we can kind of let our shoulders down a little bit and focus not just on protecting the work that we've done and that advocates before us have laid the groundwork for, but also expanding and improving access going forward. And, I say a lot, elections have consequences, and boy, is that very clear. I don't know, I wouldn't imagine that we've been able to watch President Biden's address from the Rose Garden today, but he did commemorate the 31st birthday of the Americans with Disabilities Act, and laid out a lot of good plans, a lot of good ideas about, improving opportunities, ending the sub-minimum wage, employment, advancement, housing, voting access, and he even talked about long COVID, really the symptoms that come from long COVID for some people who have it, to make them eligible for disability. And as I'm listening to this, I can't help but also think that that means more home and community-based services. That means more people who are going to need to access the efforts and the work and the workforce that we are currently trying to protect and expand. And I can't tell you how grateful I am that we have a president who is listening and gets it and supports the efforts, and wants, this life-changing, monumental $400 billion investment in home and community-based services to address and correct the long undervalued, underpaid workforce that are so critical to the success of families. And I know we've talked about it, kids do better at home when they're in their community, when they're with their family, when they are at the schools that they're able to attend. And, from a financial perspective, it is less expensive. So it's better and it's cheaper. That's the way to go. So that's really what we're trying to focus on implementing, and really help people understand the impact of what that $400 billion could do. Now, for families like mine, I mentioned we do have in-home nursing. We do get home therapies for my daughter. And of course, medical supplies. Like Elena, my daughter's bedroom is equal parts stuffed animals, toys, and medical equipment. And that's fine, that's good. That's what she needs to survive and thrive. So I will do what it takes to make sure that she gets that. In 2017, when I was sitting on the floor of my daughter's room, feeling very desperate and very alone and very helpless, I knew I had to do something. I had no idea what. I had no idea how. But I absolutely had the will And I'm leaning into the audacity to do the work that needs to be done. When I found, as I mentioned, on social media from several states away, I found this burgeoning little lobbyist group who is already making connections with legislators' offices and staffers and contacts throughout both houses of Congress. And I just offered myself up. I said, what do you need? How can I help? I have a degree in communications. I've worked for a long time in organizational communications, and I want to help. This is a life-saving opportunity for me. So I'm yours. What do you want? And I have been able to travel a few times to DC, so I could participate in a few of the lobby days. I did get a hug from Cory Booker when he was part of the primaries running for president last year. That was a big deal for me. But having the knowledge and the network is something that turns a lot of people from frustrated and hopeless and worried to empowered and hopeful and audacious. I know that word keeps coming up, but that's really what all of this is. We all know what needs to be done. We sometimes don't know how. And that's what Little Lobbyist has spent the last 4 years figuring out. And I'm being honest, we were learning together. None of us come at this from a background of, actual lobbying or, advocacy, other than the fact, of course, that as medical families, we've been advocating for our kids throughout the entire time. So being able to, have those conversations and talk to not just providers, but all of the different facets that make up our case management. I make a joke that my daughter Emma has 6 case managers, which kind of makes me the case manager because there's a lot of components that have to go together. So it's really taking that same want to get the best for your children and translating that to talking to legislators and reading and understanding policy. Which I don't want to deter anybody with, because it's not that parents have to be policy experts. We're experts in our kids. We're experts in our families and what they need. And we have, along with our kids, of course, we have the lived experience of what the policies that start and happen in Washington, D.C., as well as our state capitals, how they actually affect us families as the end users. So that's where our expertise lies. And I will be honest, that is something that a lot of legislators don't know. If you're dealing with a good legislator who's in it for the right reasons, they are clamoring to hear from their constituents. I have to tell you, watching Bob Casey today, and I've known him for a few years now, like I'm jealous being here in North Carolina that you have a legislator that is so in tune to your families and so willing to push for the things that we know and he knows are right. And even if you live in a state like me, where the legislators aren't clamoring for constituent input, that doesn't mean we don't talk to them. I've had plenty of conversations with both my senators, as well. Of course, my Congresswoman, Alma Adams, is certainly on board with healthcare and focused on the gaps in Black maternal health care. But in talking to my senators, we're not really getting to agreement, but they will never hear my silence. I can vouch for the fact that their staffers know my name, and they, I'm sure they get excited when I make phone calls, because what else is Stacey going to say today? But it's all, factual impacts of people who live in the state that they govern. And it's important that they know, even if we're not on the same side, same page, it's important that they know what their decisions do and how they impact families that live in their state. So whether or not your legislators are Republican or Democratic and support healthcare or don't, have the conversations and make sure that they at least know who you are. I was like a lot of people before 2016. I didn't really know who my legislators were. I was only focused on presidential elections, and I thought that was, doing my duty. In the past 4 years, I've gone all the way down to county level work. At this point now, the school board knows who I am, and I know all of them. And that's an important component to all of this too. It's important not just for you to know who your elected leaders are, but for them to know who you are. And that takes time and relationship to build. And I know that a lot of people, because I was this way too, are nervous to initiate those conversations because it's daunting, it's intimidating, and Washington D.C. is designed to be that way. But what we are particularly good at with Little Lobbyists is meeting people where they are and giving them the tools, the support, the bravery, if that's what it is, the community to be able to use their voice in a way that is effective and helpful and drives legislative change. So I do want to mention, if I can, Megan, we do have an Advocacy 101 training that we're launching this summer, and I would love it if we could get some contacts here, because I think it'll be helpful, especially since Bob Casey is leading the Better Care, Better Jobs Act, to just really grow Pennsylvania as a stronghold for advocates. Of course, your proximity to DC makes a difference as well. And when we can all, travel and get back on the bus again. But the Advocacy 101 session, I think, will help people get more comfortable with the idea of speaking out. Megan has mentioned too, in the last year and a half, a lot of our advocacy has been virtual. We have been making connections that we otherwise wouldn't have focused on because we would have been focusing on being in person. But now, we're talking to different media groups and other disability community organizations, and, just really continuing to grow that network so that, again, when we all speak with the same voice and we all are pointed in the same direction, we're really hard to ignore. And especially with, an administration under President Biden, where he is focusing, he is listening, he has the first disability policy advocate on staff. Like, this is important, and we can make a difference. We just need to continue to strike while the iron is hot. So thank you. I see the sign up there for the Little Lobbyist Advocacy Training. I would be thrilled if anybody wants to come in and listen, learn, practice. However we can help, honestly, we will meet you where you are, and we will do our best to get you where you want to be.
Thanks, Stacey. Oh, go ahead. Yeah.
I'm sorry, just real quick, Megan. I know I've been talking for a long time, but I also just want to go back to these babies. Elena mentioned, joy is an act of resistance. And if there's one thing that encapsulates her, that's it. I mean, these days are daunting. The world is a difficult and challenging place, and there is so much to be worried about, to fight for, and to speak up for or against. But in the same time, having that space to be a mom, to be a friend, to be a wife, those are so important. And that's why we're doing it. We want our kids to grow up to be, as successful, as happy, as fulfilled as they can possibly be. And that happens when we lay the foundation that others have started for us, keep moving that ball, and also engage our kids in advocacy as well. So that's a focus that we have with Little Lobbyists too. And again, I know, I've just been getting to know Megan and Victoria and her dear son, Cole. But I am so proud of the work you guys are doing in Pennsylvania. and just glad to be a part of this conversation. So thank you.
Thanks so much, Stacy. I know when we, when we spoke the other day, we did say, we keep saying this, the iron is hot, the iron is hot. And I want to drive that home to everyone. I know I say my son Miles is 7, so this home and community-based services life is newer to me. But Victoria and I have the good fortune to be supported by Vision for Equality, which is an organization that was started by 2 moms who could be our moms, who've been doing this fight and this work around Pennsylvania for decades. We have that to build off of here, and we're fortunate to have that, that role model. We have these role models here, and Victoria and I connected here in PA around the Nursing Summit, but we both also happen to be fans and connected with Little Lobbyists as well. And the work that Little Lobbyists does and the way you work has been a huge inspiration and sort of a pathway to the way that, myself and Victoria and some of the other families who are part of PA Families Need Nurses Now structure the work that we do. And when you said working in silos, we're all working in silos. Last year, I liked that Jeremy Yale from the panelist from Office of Developmental Programming here in Pennsylvania addressed that as well. That oftentimes government works in silos. And we know that advocacy groups, we all have our own sort of goals. And even though those goals may overlap, we have our unique interests, and we often sometimes work in silos. And then these messages get mixed. And then the action item and the takeaway item on the higher level is confusing. And, as the more we can all unify our voice and unify our mechanisms of using that voice, how much more powerful and how much more helpful is that to those who can implement change, to hear these unified messages. And actually our keynote speaker last year, who's the former Deputy Secretary of ODP here in Pennsylvania, Nancy Thaler, who's a huge champion of children with medical complexities in PA, she talked about that last year, about, unifying all of these organizations, unifying their message, or at least getting on the same page about what's being communicated. That's going to be what moves mountains. That's what's going to make an impact and make a clear, direct, actionable change be able to happen. So we're so excited that that we are connected, and we of course, and I'm sure Laura would agree, Pennsylvania families and Pennsylvania providers want to connect, and we want to make sure that that all of these groups are working together and in concert. So I'm glad to hear you say that too. I think it's such an important message. I'm glad. I think, Victoria, are you able to drop the actual link for signing up for the Advocacy 101 training into the chat? These slides will be available to participants after the event, so they'll have that clickable link, but we'll also put it here in the chat, Stacy, so that folks can start signing up. I signed up the other day. So once the announcement is made for when that advocacy training will be, we'll all get alerted. And it was a very quick and easy way to sign up, and then put it out of my brain, because fires are always happening.
Yep.
So I look forward to that reminder that it's going to happen. And thank you for talking about this. You're right. It's that hurdle of, how do I even begin this conversation? I'm just one mom. And once you get past that part, there are so many connections to be made, and there are so many easy ways to make your voice be heard, as easy as it can be for a mom who hasn't slept in 4 days. But, maybe that's when we're at our most lucid.
I'll buy that.
Laura, thank you for hanging in there. We are super excited to hear what you have to say. Hearts for Home is such a unique organization. It's such a unique arm of your organization. So by all means, please let us know, if there's anything that we need to add to these slides when we share, or if there's anything you want to share in the chat, we can drop it in there for you. But go ahead and tell us about Hearts for Home. Oh, you're still muted.
All right, there we go. Well, thank you, Megan, and thank you everyone for having me back today. I'm very excited to be here, and it's really an honor and a privilege to speak with you all today and to hear your stories. It's been a wonderful experience so far. So I as Megan had said, my name is Laura Ness. I'm the Area Director of Government Affairs for Beata Home Healthcare, and I serve the Mid-Atlantic region. So I cover Pennsylvania, Delaware, Maryland, as well as the Midwest. So we do some work in Indiana and Missouri. So it's percolating our message and our program throughout the United States, which we love. And really, this program started over a decade ago at Beata, when we noticed that we were spending a lot of time and effort building relationships with our hospital systems, with our nursing homes, but we were doing kind of very little work with our largest client, if you will, the government, our state governments and our federal government. So out of this, our government affairs office kind of formed. And then from this, we formed this program and this what will soon be a separate organization called Hearts for Home Care, which is really our grassroots advocacy program. So that is the initiative where we are really trying to involve our caregivers, our clients, their families, their friends, to come together and speak to our state legislators, our federal legislators about home health care. This is an issue that, as Stacy had stated, I am so thrilled to see that it's garnering more and more attention and it's becoming a hot button issue. When I started this effort, and at Beata 10 years ago, and telling people that I was doing advocacy work for home health care or for home care, I would have people say like, oh, is that like cleaning houses and like roof repair? Like no one even knew what it was. It was a very, to put it, unsexy issue. And since then, we've really seen it blossom and grow where, individuals do understand what it is. And, one of the, if I may say, silver linings of COVID is that people now more than ever have this desire to get what care they can receive in their homes and in their communities. They want to stay there. They want to be at less risk of infection than going into the doctor's office or going into the hospital. So it's really begun to show how important and how this care is really essential to the health of our communities and to our society, and how it can really make a difference. So we spend a lot of time every year looking at what is going on the state level, especially, as well as the federal level, and saying, where can we impact change? Where can we change things? Where can we remove duplicable regulation that is just taking up more admin time? Where can we work to increase reimbursement rates so we can pay our caregivers better and close missed shifts and serve more people, get more kids out of the hospital? And we either through these conversations with our employees and with our clients and with our other competitors, we come up with our goals and we kind of work towards achieving them. And that's where kind of my job comes in with putting together that plan, but that's where all of you come in as well, as far as getting that message heard. Because let's give an example for Pennsylvania, since we're talking about that today. I am one person, and there are 253 legislators in Pennsylvania alone. Pennsylvania has the largest full-time legislature in the United States. So even if I wanted to, I could not develop relationships with each and every legislator. And quite frankly, each and every legislator is not invested in a relationship with me, because I can't vote for them. I can't contribute to their campaigns. I can't be in their community and know what's going on. But our employees can, our families can, our friends can. And that's where, this kind of mentality that it takes more than just one or two people has really been born. So, one of the pieces that I do is kind of evaluate, when do we send letters to the editor? When do we use social media? When do we use emails? When do we go and do meetings? When are these things going to be most effective? And then, deploying those options and those opportunities and asking all of you to kind of advocate and take initiative and do those things. The other major, I'd say silver lining that COVID has given us, and I know that Stacy said this, Megan said this, everyone's saying the iron's hot right now, right? I'd like to offer kind of a slightly different take on that, is that COVID was the equalizer. It was the great equalizer for this population. Individuals in home care are homebound, right? Like for Medicare services, that's a requirement before you can even be eligible, is you have to be homebound. For our kids, we have many NICUs in the home. They can't just get out and do so easily. We know our parents are going off days without sleep. But with COVID, everything went virtual. So all of a sudden, you don't need to travel to Washington, D.C. to meet with your legislator. You don't need to travel to Harrisburg to meet with your legislator. It is as simple as calling the office and saying, I want a meeting, and give me a Zoom link, or send me a phone, send me their phone number, and setting it up that way and having that conversation. For the 2020 and 2021 budget season, I had 0 meetings in person the entire time. We were only doing virtual visits, and we have had hundreds, literally hundreds of those virtual visits. And one of the things that we're finding is that they're better. Our legislators spend more time on the computer with us, on Zooms with us, on or Google Hangouts. They are paying closer attention. They're spending more quality time. They don't have to worry of running off to go drive to the next event or to run down the hall to cast votes. They can literally have, even some of them even had 2 computers open. One for when they got called back into session, they could step away and go cast their vote or do whatever, and one for our meeting. It was incredible to kind of see and operate. So it's so wonderful in that sense that now we're beginning to see the kind of the leveling of the playing field when it comes to advocacy. And our legislators are really kind of enjoying the aspect of being able to not only see you virtually and have that kind of convenience, but taking away the virtual background and then being able to see the mini NICU in your home and show the different pieces of equipment and show, all of these pieces of what it takes to deliver this kind of care in the communities. So, with being part of Hearts for Home Care, we really strive to, again, like little lobbyists, meet you where you are. We have spent the last decade training our employees to be advocates, to understand how to advocate. And one of the things that we've been able to do and kind of cultivate with them is, gaining others, allowing others to be involved in this and helping them through that, helping them be a part of it and encouraging that participation, growing and nurturing that participation. So if you find that you're not ready to do a meeting just on your own or by yourself, it's too daunting and too intimidating, that's okay. We will pair you with someone who is very comfortable with that and will provide for you opportunities and remind you of how to tell your story or to expand upon this point or that point, to really make sure that you're beginning to develop that relationship with your legislator on your own. So that is also kind of a main crux of our program is we call them ambassadors, and they are advocates that are trained in having these meetings and helping to build these types of relationships, but also bringing more people into that sphere and talking about that more. So if that's something that you, again, are also interested in, we do regular advocacy trainings. You can join us by our Hearts for Home Care website. There we go. I'll type it in the chat here now too, so you have the link. We just redid the website. There we go. Or our Facebook page, which is Hearts for Home Care. We would love to have you there if that's something you wanted to get a more direct line or communication with us. We have our email there as well as our phone number. We would love to have you, love to learn more about your stories. And we are working really hard to kind of involve more of the community. I know today you talked about that, the Philadelphia Inquirer story. That was something new that we've kind of added to our advocacy arena, and kind of creating more of a public awareness around these programs through public affairs, through earned media. So if you read that news story, Beata Home Healthcare was quoted in that several times. A lot of our competitors were quoted in that, and that was something that we helped facilitate. First of all, get the reporter interested in doing a story like that, but then also take it one step further and make sure that they had, a lot of client perspectives, and an individual that was still stuck in the hospital waiting to go home, and other organizations and our home care association involved. And so what you ended up with was, in my humble opinion, a very well-rounded article that really spoke to the issues that we're facing here today. And ultimately, it really led to our ability to get that $5 per hour increase in the pediatric shift nursing rates for Pennsylvania. So we were thrilled to see that happen. It wasn't everything that we asked for or wanted. We were looking for $10, we got $5, it's halfway there. But out of all of the different home care programs, and this budget being a very tough budget session, where they were kind of kicking the can down the road of funding a lot of these programs, this was something that legislators heard about enough that they decided that now was the time that they needed to make an investment, with federal funds aside, that Pennsylvania needed to invest in this again and do so more heavily. So, if there's any questions, comments, anything I can help answer as far as, the kind of work that we do, or how you can get more involved, I'd be happy to do that. It's been a passion of mine for over a decade in PA, and I am pleased to say, and I don't know if this was said earlier today or not, but I had spoken with Megan about this. If you kind of line up all of the states, Pennsylvania certainly has some work to do as far as its equal access to home and community-based services, but their private duty nursing program, our pediatric shift nursing program, is one of the strongest and most robust programs that there is in the state. So, it's something that I'm very pleased to see. Of course, we can always improve upon it and always do better, and there are many opportunities to do that. But it has been evident that our state has cared about this population and has worked to improve upon it. And that's what Hearts for Home Care does. We worked with the state to create that the skilled nursing summit, the workforce summit that we had a couple of years ago, and to really bring together managed care organizations as well as providers and the state and families to kind of see where we can develop some synergies and can solve some problems. So it's never easy. It's never kind of a one size fits all solution, but it's something that with constant feedback and with a strong group behind it, we can really move the ball forward.
Thanks, Laura. I do want to, I'm a little echoey. Let me see if I mute and let's see. There we go. Fun with technology. Several things you said really struck. Victoria, myself, several other families that we know were able to take part in that OMAT, the Pennsylvania Office of Medical Assistance Programming Shift Nursing Initiative. And, it was said several times earlier, you know, Amy Millar says it best when she says nothing about us without us. And I think that for one of the first times around this issue, you know, family voice got incorporated in a really functional and structured way by having families participate in that process. And it really impacted the deliverables. And hopefully it will impact the way those deliverables are delivered going forward. And you're right. I tried to highlight this a lot throughout the summit, that Pennsylvania is unique, especially on the pediatric side. When it comes to private duty nursing, we have one of the most robust systems of medical assistance. We have, you know, we're a large state, but we have a lot of providers. And I shouldn't say that, you know, I know it's tougher in rural areas, but you know, for all intents and purposes, again, using my family as the example, my location, my specific location, and my setup as an example, Pennsylvania theoretically, given our robust Medicaid structure, we should, you know, families here should be experiencing a level of in-home supports that other states maybe don't. And it's really that lack of workforce that's the barrier now. So, you know, obviously, again, on the adult side, it's a whole different story. We have a waiting list for waiver services, and there may be people who can't access those services because they haven't simply gotten the waiver yet. And that's another side of expanding home and community-based services and attending to those folks languishing on waiting lists. But once we get folks on the waiting list, if they're still medically complex and they're now eligible for home and community-based services, if those nurses aren't there, the service still can't be provided. So I think what's wonderful, it's wonderful to get a rate increase. And it's wonderful that we all come together and that we have we're bringing all of these perspectives and all of these experiences and having these very candid and hopefully productive conversations around each user's experience, ultimately with the individual who utilizes the services in mind. So something you said made me think about, just a quick aside, when we're talking about getting involved in advocacy and when we're talking about who can and should advocate, and the answer really is everyone. Even if you're not a provider or a user of home and community-based services, you're not the Laura Nesses, the Stacys, the Megans, but it's, you're a supports coordination person, you work for an SCO, or you're at the special needs unit at the MCO. And in your professional world, you do this thing, but in your personal world, your legislator needs to hear what has to happen for the people you support in your work. That's you too. That's not just the family stories. It's not just the provider stories. It's the community stories of how important it is to the community to have our children and our husbands and our wives and our moms and our dads and our grandparents in our homes and in our communities with us. I have a friend in California. He's an Irish guy. He moved over to the States. He's now an American citizen. He's a super proud American citizen. And he's so put out from across the country. He's so put out by the experience my husband and I have with Miles. He's now calling his legislators in California. He wanted to know more facts about this. And he is calling his legislators in California and reminding them that there are kids like Miles in Pennsylvania. I mean, there are kids like Miles, his friend in Pennsylvania, in California, and adults and grandparents who need these services. And that's one guy, but that's the goal, right? To get everybody on all levels really engaged and understanding that this isn't just for our community. This is for the community. This is so that everyone can be part of the community and make our communities what they should be, inclusive of all people.
Can I piggyback on that for a second?
Yeah.
This was something I know you and I had talked about, and there are so many people these days that are one issue people. They will only vote for a legislator based on their vote on this or that, and there are always controversial topics on guns or this or that. This is a service that affects like not even the livelihood, just the ability to live for so many people. Yet we're not at the point yet where we see this being the one issue that people care about, that they vote on. Why is that? This is in more ways than you can even imagine, has a direct impact on how our loved ones and how many of us live our life every day. But when it comes to the voting booth, it doesn't enter into our frame of reference. We don't think about it at all. And I know that's one of the things that, being in government relations, we have to do a better job with providing, people's positions on and where they fall as far as in the structure of support as an industry. But, ask your legislator, will you vote for this? Will you prioritize this over other things? Will you, when it comes down to it, be a champion for us? Will you make that hard decision? Because that is, that's ultimately what's going to really elevate our issues and get more people into these positions that are making these decisions that are going to have a positive impact on the services that we get, and how our programs are delivered in our states, is if this becomes our issue.
Stacey, I wonder if you can respond to that a little bit, because, I know we say little lobbyists denotes the idea of small children receiving home and community-based services, receiving medical assistance. But those little lobbyists, God willing, grow up into big lobbyists, we hope. So I know, little, I don't want people to mistake that you only focus on children or pediatric issues. Oh, no. Certainly your organization focuses on, healthcare for all people with disabilities, medical complexities in the community. So, a couple things, how do you have the Advocacy 101 information coming out. What can we all be doing? What can we all be doing besides, me and, harassing my friends all the time, which is, I guess, what we can be doing. Harassing my friends. This is a problem. Start talking about it. What are some ways we can engage people who aren't directly impacted by this and make it like what Laura said, like why isn't it? We all know nurses. We all know families with a disabled loved one. We all know this is legitimately an issue that impacts basically everyone we know in some way or another, but it doesn't seem to be what takes them to the voting booth. So what do you think? What are we missing here?
Well, that's a big question. I think that, Laura, you've really nailed it in that it is everything. It is all of the things, and it becomes the single issue. It's disability in the form of educational access, community inclusion, public education, fair and accessible housing, wage growth. Little Lobbyist has kind of a set of guiding principles. One of them is that all means all. As we were watching the turmoil at the southern border, that persists, but what was very dangerous under the previous administration. And we know that a lot of the reasons that people are coming to our country to seek asylum is because their home environment has pushed them out, either through climate impact or, government instability or access to healthcare. There are children, there are families, there are people coming to our southern border with medical needs. Kids with trachs, kids with different medical diagnoses, and they aren't getting the care that they need. So that became we were sitting, actually it was, I'm gonna call it a virtual kitchen table because we were on a phone call saying, can we pick this up? Can we add immigration, to our things that we advocate for? And the answer unanimously, yes, absolutely. This affects everybody. And it's that kind of big umbrella that we are striving for. If you're not looking at the intersection of race and gender and geographic location and all of the other things that go into the social determinants of health, you're not doing it right. And I think the thing that we can be doing in the very short term, Megan, is having those uncomfortable conversations with the people in our lives, talking to family and friends and voters, people who maybe don't think it directly impacts them, and say, here are the myriad of ways that it actually directly impacts you. And here are the reasons why when we all do better, I'm going to be Joe Biden for a minute, when we all do better, we all do better. And it's that drive toward community. And that's something that has really struck me about our nation's response to the COVID pandemic, that there are some people who are so clearly working for the community, and there are some who are so staunchly focused on the individual. So we're going to have to be that bridge. We're going to have to start the conversations and say, here's why it's not just you, it's us. And I keep referencing Elena, but her keynote speech was so good. When she was talking about the quote from Ayanna Pressley, the people who are closest to the pain should be closest to the power. And I don't know if I mentioned, but my daughter Emma, with her tracheostomy tube, she doesn't phonate, she doesn't make sound. She absolutely has a voice and needs, wants, and desires, all of those things. When she can self-advocate, nobody will be happier than me. Until we get to that point, I will do it because that's what needs to be done. But I absolutely believe in lifting up the people who are most affected by the issues we are trying to solve, and really taking a look at not over talking them, not grabbing the mic, although that's something I really love to do because I like speaking into a microphone. But we really want to be able to pass the mic is the ultimate goal, and get more people involved and get more people engaged. And that's everything from local politics, local legislation, local voting. Elections happen every year. It's not just the president and the Congress. Things are happening right now that affect our schools, our cities and towns. And it's a lot for sure, but it's a very important component of life to get engaged in. So I think the more conversations that we have, the more people we can talk to, and again, meet them where they're at, start where they are, and then bring them along, and be willing to, listen to the things that you identify as barriers. It has to be a two-way conversation. We just have to start it, just because it hasn't been happening so far. So I don't know. Did that answer the question?
Yes, I believe so. I have a message here. Dorothea wants to answer a question or ask a question. Do we have the question in the chat? I want to be mindful of the time. We are close to our 2:30 start of our next panel. Victoria, if you're able to see the question, do you want to unmute?
She did not ask the question, but she asked to ask a question.
Oh, I see. Let's see. There we go. Okay. Dorothea, I'm going to have you unmute for a moment. You should see a button. Are we there, Dorothea? Can you? I see you're unmuted, but I don't hear you. Okay. Unfortunately, we're going to have to move along. I'm not sure, Dorothea, if you're able to type a question into the chat. We can try it that way, or if you want to reach out, we can ask a question after the fact. So, by all means, reach out to me. I think you have my email address. But we'll connect, I'm very fortunate to be able to stay connected with Laura and Stacy. So Dorothea, whatever question you have, we can explore it after the fact. Laura and Stacy, I want to thank you both for being part of today. This has been hugely helpful, I hope, for the folks. I mean, it's hugely helpful for me, and I feel like I'm advocating all the time, but I always learn something new when I talk to both of you. And so hopefully our participants did as well. I hope everybody wants to stick around for a little while longer. We have a really interesting info session coming up from the Technology Assisted Children's Home Program, who's creating an app for caregivers to use called Shift Check, which will help organize, track, and provide a little bit of accountability even for missed shifts that are covered, etc. So it's an app directly targeted toward caregivers who've utilized shift nursing in Pennsylvania. So I hope everybody stays on and hears more about that. Stacy and Laura, thank you so much, and we'll be in touch soon. I see Erin, we have you here as a panelist. We're working on Missy becoming a panelist. Let me see if I can get her. I'm not seeing her in our list. I wonder if she lost her connection. But we have your PowerPoint ready. So if you want to jump in, Erin, thank you for joining us today. We're really excited to hear about Shift Check. I know this has been a labor of love for you for the last few months, maybe longer. And as soon as we have Missy in, we'll bump her up and get her video going.
Sounds great. I am here. Okay. Thank you, Megan. Are we good to go?
Yeah, so, I'll just give really quickly, Erin Johnson is the program coordinator of Technology Assisted Children's Home Program. Missy Modesti is the program manager of the Technology Assisted Children's Home Program, which you'll hear us call TACHIP throughout this presentation. And they have a pretty robust presentation today about an exciting new platform that they're trying to create for caregivers like me and caregivers like some of you and those that you support. So without further ado, here are the TACHIP presenting Shift Check.
Thanks, Megan, and thanks, Victoria. Today already has been so informative and so diverse in the conversations we're having. I'm really excited. I know Erin is as well, to have the opportunity to finally present an idea that came to fruition, well, an idea that started to come to fruition about a year ago. And here we are to talk about an app that we've been working on called Shift Check. You can switch slides. Just to give a little background, so we are from the Technology Assisted Children's Home Program, which is actually a state initiative funded through the Department of Health. Our office is located in Philadelphia, but we serve 31 counties on the eastern side of Pennsylvania. And our main responsibilities as a program is to serve and support families who have children that are tech assisted with whatever that might look like, advocacy, education, coaching, resources. I will tell you honestly, a lot of what we end up doing is trying to get accurate and appropriate IEPs in place. We try to bridge communications between systems, ensure medical plans are appropriate and what parents are asking for and in need of. And then we, of course, spend a lot of time helping families navigate their nursing, their home nursing, the agencies, connecting to new agencies, and hopefully through this, connecting with other families who are experiencing the same difficulties or the same triumphs, and able to share what has been successful. We are a home visiting program who, like all of COVID, had to quickly and swiftly shift how we delivered our services. We were already providing families in our more rural areas with tablets. So we immediately switched to a full virtual format once COVID hit to be able to ensure we were still meeting with families as much as was needed. Typically, we meet with families on an as needed basis. So if families have more immediate needs, we're meeting with families once, twice a week, either virtually, through text, through calls. And then as supports begin to come to fruition, we'll start meeting with families less and less or as needed. Once COVID hit, we kind of put a halt on any discharges just because things were coming and going so quickly and so much was unpredictable. So we've left that open. And what we found is, 4 months will go by, 5 months, and then we'll get a call and we'll begin pretty intensive services again until whatever is going on has been cleared up. You can switch slides, please. Just a brief background about who we are. TACHIP was formerly the Ventilator Assisted Children's Home Program, which had been housed at the Children's Hospital of Philadelphia, CHOP. When it switched from the ventilator program to TACHIP to what we are now, the biggest concern from families who were in both programs is that the ventilator program offered respite services, or at least funding to get respite, and that was removed by the Department of Health when the programs changed. It's something that we continue to kind of work towards and advocate as a program to the Department of Health and to the state about why that has been difficult for many families, the need, and kind of like this magical word respite now. Again, we're serving 31 counties in Pennsylvania. We've worked closely with another, a sister company in Pittsburgh who was working at the Children's Hospital of Pittsburgh with families with tech-assisted children coming into their hospital, a little different format than how we worked with families. In addition to our home visiting program and the families that we serve, we also host what we call EPSNA, the Eastern Pennsylvania Special Needs Association. We do this in collaboration with resources, with agencies, anybody who is able to offer families who are raising children that are tech-assisted or with medical complexities, any type of resource, any type of help, any type of program. And we use EPSNA as an ability to highlight what those programs may be able to offer. You can jump, please, to the next slide.
We've had a little bit of lag on the PowerPoint. Here we go. Oh, and just a heads up, here's where we added your poll.
Oh, perfect. So we did want to do a quick poll of what would best describe who you are, who your position is, and why you're here today. It'll look very similar to the one that was asked in the beginning of the summit. Awesome. This is great to know. Thank you for everyone who was able to respond. So it looks like we have a lot of government and non-government agency attendees today, as well as parents. and some nursing agencies, home care nurses. Thank you all for attending. And as we move forward, any input and questions would be greatly appreciated. Are we able to switch slides from here, Megan?
Yeah, if you just say next slide, Jen, I'll handle it. And if the questions come up in the chat or some conversation comes up in the chat, I'll just give you guys a heads up.
Sounds great, thank you. So in our work with the families that we serve, obviously this, as I mentioned, nursing, the nursing experience, both triumphs and troubles, we've noticed some themes, some repeats. So we started talking about this as a group more thoroughly. A lot of it around, the need to match family need with nurse availability, as well as the insurer issued number of hours, and how that really meets the family need, matching skills and training of home nursing staff. The uniqueness of each family. Megan, you've spoke many times today about how your situation is ideal, and it's still a struggle. And all the families that we're working with who might not have this quote unquote ideal situation, but still need nursing in order for their loved one to be able to live. And for parents to be able to either care for other children, have somewhat of a relationship with family, friends, significant others. And how do we highlight that uniqueness? We have talked in depth with parents and other professionals in different capacities about parents trying to get paid as caregivers and what that looks like, and those who actually meet that status, what it took to get there. Again, the magical world of respite care, and I think those who have been in this world knew what it used to be, what it is now, and how it's important as it ever has been, but how it's almost impossible to get. And also I want to add appropriately trained respite care, because that's another theme that comes up a lot. You can go to the next slide, please. And knowing what's on the next slide. So just continuing with the home nursing experience, what we are trying to really include in this idea of an app is how do we highlight the experience? So we have families who consistently ask all right, I've been told I need to advocate, but who do I do that to? And what exactly am I advocating for? And it's a question we work through with a lot of families. The impact of immigration status and primary language other than English on home nursing. Through this project, we have had the opportunity to interview families whose primary language is other than English. And we've had families who have said it hasn't played a role at all. And then we've had other families who have said it's significantly impacted their ability to get in-home nursing. So we just started to highlight that as well. Again, in a household that relies on home nursing, as you guys are aware, changes happen, frequent changes, high needs. And how does that impact nursing? And what do we do then? Managing multiple staffing agencies, for families who have been in this game for a while, you hear oh, when my child or my loved one came home, we had one company, they were great, we didn't want to leave them. And that almost seems like a unicorn at this point. It's so rare that I have families who say they only have one family. It's, adding up 3, 4, we have families with 5, 6, 7 different companies that we rely on. And it's the family who is managing all these different days and trying to keep track of the schedule and stay on top of the nursing agencies as well. The impact of delayed discharges. We had some opportunity to spend some time at the Children's Hospital of Pittsburgh as we were kind of creating this idea. And so I spent some time with the social workers in the NICU, and they talked about how there's babies there who have been, their stay has been extended months, 3, 4 months at a time, because they're not able to find a in-home nursing staff and agency that can guarantee those first 2 weeks that need to be guaranteed for the insurance to approve the discharge. And how does that, what are the impacts and implications of something like that? And not just, at the NICU level, but when children are home, loved ones are home and have established nursing and have a medical setback, and then trying to get back into the normal life, and that in-home nursing becomes an issue again, what happens then? Access to stable housing for families who might not have stable housing, but still have nursing needs. How do we manage that? How do we navigate that? How do we bridge communication between the family and staffing agencies to be able to address that, and everything that comes with that, as well as caregiver health status? It's great. It's not great, but if you have a family who isn't able to get the overnight nursing that they need, and you have a parent or a caregiver or a loved one who's able to stay overnight and work that out somehow, but sometimes it's just not feasible for some of our families, and then what? So we do a lot of management in that as well. Next slide, please. And then, of course, just the impacts on the quality of life for the caregiver, which is financial, the impact on siblings, the impact on all relationships, the logistics, the tension, chronic fatigue, self-care, isolation, all of these things. And one theme that we heard off and on throughout today so far is like the family voice, the family experience. And what we noticed is all of the families we were speaking with and who were willing to share their story talked about the quality of life impacts in one way or another, but had no way to really validate that experience. How do you prove that? How do you show that? How can I show somebody I have this chronic fatigue, I haven't slept in 3 days, but I'm still making life work because I have to. So all of these, experiences shared with us by the families we serve, and as Erin will share in a minute, that she experienced herself and a few of our staff members have experienced themselves, really drove us to say, like, I know there's these amazing advocates out there, like Little Lobbyists, Megan, Vision for Equality, PA Families Need Nurses Now. How can we assist in this process of making change in a way that really highlights the family voice, the caregiver voice, the need, in a way that also gives supporting data? So that's where, this is where we've ended up. Next slide, please. So I'm going to let Erin kind of take over from here.
Thank you, Missy, and thank you everybody for having us. It's awesome to be here. So Missy summed up a lot of the background really well. I can just tell you, myself, I was teaching at a local university, public health, to nursing students. Actually, I have a nursing background, but I was looking at the public health side when my daughter was diagnosed with leukemia at age 11 months old. And we ended up in the hospital for 250 days, plus, all the day visits, and we were not authorized for nursing care. And I'm a single parent, so luckily I had a mom who was willing to step in, and we did all of the stuff, all of the, daytime, nighttime management, chemo, blood pressure checks, pain management, nausea, PICC line management, all that stuff. And that was right before I came to this position. My background before this position was actually working in environmental health, which is quite different, but I was fortunate to have a nursing background to become a parent nurse at home. So it's a silver lining, but I really got a firsthand view of a lot of the situations that parents are in and families are in. So that was my daughter's treatment, and luckily she's doing well today. Was right before I started this job. And then I started hearing about all of the families and their stories with nursing care and respite care, and understanding the history of our program before I stepped into my position with the respite care, with the previous program going away. And I myself had looked for respite care, found it nowhere for pediatric care and just for elder care. So it was all just kind of eye-opening, and I just kept listening and then reading literature from, research literature on this problem, and then listening to my colleagues. And we went to speak with a couple legislators, and we also spoke with nurses and nursing agencies. So we started to kind of gather all this data in our heads, and I kept talking to Missy. I'm like, what can we do? What can we do? What can we do? So for my previous job, Milk Crate had kind of reappeared in my life through an email, and I was like, and just kind of the idea started percolating to create this app. And it was wonderful that our department, the Health Promotion Council and the Department of Health were very supportive of us working on this and dedicating time to this project, because it has been a bit of time. We have worked about a year on this project. Next slide, please. Can we have the next slide?
So sorry, I think it's lagging again.
That's okay. No
Let's
worries.
see. There we go. It was pixelated at first. It's there.
That's okay.
Sorry,
That's
Erin.
okay.
My computer is lagging behind. I apologize. There you go.
Oh, no problem. So we started to kind of come up with the idea of, if we created an app, which is something that a small program and a nonprofit could do to kind of contribute to this, to trying to address this issue from a parent caregiver perspective, that it would be family centered, it would focus on caregiver experience. It would be a tool for personal record keeping. So a lot of people are using pen and paper. Awesome. This would be a digital method to do the same stuff, and some of the same things, some new things. It would also give people who enter data a historical view of whatever data that they put in, so they could look back at their what they put in for themselves and also for advocacy purposes. We wanted to emphasize the customer service side of this, since a lot of the families that we work with, we're working with them because there's a need, right? And that need is being addressed by various agencies and entities, including home healthcare staffing agencies. And we were hearing a lot of positive stories and a lot of stories where there was clearly the need was not being met. So we wanted to focus on customer service as kind of is a service being met? Is it not? And to what degree? And what is working and what is not working? So that's granulating the data a little bit more so that we could contribute to the conversation, the bigger conversation like the one we're having today, with more data points that advocacy and visibility. So kind of being able to see trends, being able to have data to underscore people's stories that they're telling, and to then amplify the caregiver and family voice within the conversation, the larger conversation about this home health nursing shift crisis. Lastly, we were talking about, and we have found ways to be able to aggregate that data so that we can begin to see patterns of change. So patterns of need, patterns of change, patterns and trends. Since we serve 31 counties in the state, we do have kind of a long view of the trends across the state and how things have been changing across rural and urban areas, and for immigrant populations and people who whose primary language is a different one other than English. So we wanted to really be able to see trends in order to better have conversations that are useful to say, this is what we see going on with the families that we're serving. Next slide, please. So the actual functions that this app has ended up having, so it was a long birth process of about a year, and it's not done yet, but we're almost there. So this is an iterative in the works process, and we are so happy that you all are here, and we welcome your feedback. There will be chances to give feedback later, but we can run through the functions that we have created now, and we welcome your feedback on those. But we have developed a nurse roster, so that is a way for a family caregiver to put in information about a nurse who comes to their home, name, where they came from, what dates they were in service. Just because if you're in a chronic care situation, sometimes it's hard to end with the 5 or 7 agencies or 3 agencies in your home. It will help families to keep track of who was in their home and when. Completed shifts or disrupted shifts. So there are surveys with questions that people can input. If a shift was completed, was it completed to satisfaction? Again, going back to, was the customer service need fulfilled, right? This family had a need. Did the nurse was the nurse able to meet that need and to what degree? Disrupted shifts, we've talked about that there's insurance allocated hours, and then there's nursing that does or does not meet that number of hours. So if a shift was disrupted, what happened? What was the impact on the family or caregiver? Did they have to make phone calls? Did they have to rearrange schedules? Did it affect sleep? So we're really looking at quality of life impacts and helping families to find a way to document that where it's all kind of in one place and with the historic view over time. Like, oh, why did I have to take FMLA so many days? Right, this is what was going on. You can have that information in the app for employer advocacy or conversations when you're trying to navigate all of these changes. So those are some of the aspects that we have. Delayed discharge, the same thing, we've been talking about that today. What happens when there's a child who is in the hospital and there isn't nursing service, so that they can go home. Again, quality of life impacts on the family, what is happening from the family's perspective. Medical setback, same thing. If a child has a new diagnosis or has something happen that affects their health, what quality of life impacts and logistical impacts happen for the family as a result that is also tied to nursing care. And then there is also a place in, and I've mentioned quality of life impact throughout, that's really throughout the app. One can also upload images. So taking photos with the phone of if there's a care issue or care documentation or to enhance communication. Because you need support for something, that is all in the app as well. It can attach images to a day, to the entry of a day. So it's timestamped with that day. And then there's resources as well, statewide resources. And we've been researching which ones are offered in other languages. So we're trying to offer this app in English. I don't know if you said this, Missy, English, Arabic, and Spanish. For starters, so this will be offered in those 3 languages, and then hopefully in the future we can migrate to other languages that are prevalent in Pennsylvania. But resources that are offered in the app will be ones that offer them to folks who speak other languages other than English as well. And then there's an activity feed so that caregivers can connect with each other, share resources, and people will be able to look back at the data that they have input. So if you could go to the next slide. So some of this reiterates a couple of things that I said, but it is free. It's a free app that we hope actually removes barriers for folks and can be used by caregivers across the state and beyond as is needed. We've also been writing the language within the app so that caregivers of the elderly or other folks who are not in the pediatric home health care setting can use the app. The data that's collected is aligned with codes from Medicaid, so that when parents and professionals from Medicaid are communicating, that they're all on the same page as far as what the parents are reporting, the parents or caregivers are reporting, and what Medicaid is reporting, in order to facilitate interdisciplinary communication across. There's text boxes for notes throughout. There's and then there's resources. So I've mentioned a couple of the other functions and what we're trying to really help focus on. Next slide. So we have a couple of the screenshots to share. It's in development as we speak. So these are not the final versions by any means, but hopefully we'll give everyone a view and kind of an idea of what the app will eventually look like. Some of the images are being changed around, some of the spacings being changed around, some of the buttons, but basically this is it, with ways to log information per shift and ways to log information about nurses, resources, if your nursing needs have changed due to delayed discharge or medical setback, for example. And Missy, feel free to jump in at any point. The number 2 view over here is the completed shifts and disrupted shifts. So if on a given day, there's a family that has a disrupted shift that they want to document something about, they would just click on that button and there are questions in there. Nothing is required. It is all completely optional, voluntary, and it's really for the family and caregiver to document for themselves what happened that day.
I just want to reiterate too, that the documentation is family driven, caregiver driven. Yeah. Families could fill this out daily. They could fill it out weekly. I think back to the 2019 Nursing Summit. Erin and I have talked about this a lot. I had attended with my supervisor, Lamia, and I listened to so many families and parents talk about like writing in notebooks, like vigorously tracking the data and trying to remember things, which was another like helping point to like how this app came about. But I also heard families saying I would do this every day, or I would do this once a week. And we really contemplated like how that would look, and just realized like, we'll just leave it totally family driven. You know, this will be up to the caregiver when they feel like it, when they have time, when they have the energy, which could be daily, which could be weekly, which could be monthly, whatever really works. So like Erin had just mentioned, it's very much, it's family driven, caregiver driven, and up to you, nothing would be required.
Next slide. So a couple more of the screens. I mentioned this one before, if the nursing needs have changed. And then the resources section that we've divided into categories. Next slide. And then, as I mentioned, there's also a section to just kind of like try to help keep track of who's coming in and out. Some people have nurses for 15 years and there's nothing, you know, that's steady nursing service, and they know who's coming to their house every day. So that may not be relevant for some families, but for other families that have multiple agencies co-vending in their home, this feature might be useful to help kind of jog memory when someone shows up on the front porch that has been there before, and when they were there. Okay, so that kind of sums up the general purpose background and the current look of the app and the functions. Next slide.
Erin, I want to see if it's okay to interrupt just for a moment. We did have one question from the crowd. Dina asked, is the information in the app going to be tracked or reported to DPH or the MCOs? Wondering if this can be used in real time to assist families in getting care.
That's a good question. We did not conceive of it that way originally, and perhaps after we get it up and running for a while, and if that appears to be a wish of more people who are using it, many users, we could morph it into that direction. Currently, it's just designed as a personal tracking tool that we can see. Just TACIP would be able to access the data in an aggregated fashion. So we can see trends, like say there are many missed shifts, disrupted shifts in one county versus another, that kind of data. So it would be kind of patterns that we can see now, but we have not, that is a great point, and that's not part of our current working app, but it's definitely something that we can keep in mind going forward, for sure.
And I do want to add, it's an interesting comment because we've heard from some families when we started these discussions that data security is very important. So as of right now, the data will not be shared with anybody from our end. We don't meet exact HIPAA compliance, but there is no data selling, data sharing. It'll all be protected, and it'll be up to the family because families, the caregivers, are the ones who are able to run the reports. And it would be up to them if they would want to share that data with anybody. Now, what Erin and I will be able to do is, like she was saying, look at aggregated trends, like look and pull data and see if there's, areas that seem to be happening for every family. What can we share? What are we seeing that we can bring that data to larger tables, larger discussions. But as far as personal data, that'll be protected and only used by the family if they wish.
I think if I could just add on to that, I think one of the things you built in here, though, is that as you said, the sort of reason codes for missed shifts that families will be able to track in this app are sort of a mirror of the medical assistance reporting structures for missed shifts from the agency perspective, so that there's potentially a unique symbiosis there, where those pieces of data could be compared to see what the trends are and where there might be disconnects. But I know who Dina. Hi, Dina. Thank you for being here. Dina is an agency representative who is such a great family advocate, and I can foresee Dina wanting to, perhaps utilize information like this to show the payor what's going on. So what would you say that on an individual level, families and agencies on their behalf could potentially use their individual data to perhaps advocate, champion for a specific issue?
Yeah, that's how it's currently set up. So that the control is fully within the caregiver and family, like that's the locus of control for the app and the input. I mean, they're putting in the data, right, themselves, but that they could on an individual basis use that information absolutely to kind of to bridge the communication and see where maybe miscommunication is happening or different perspectives on the same issue are happening, which was our idea, is to kind of try to create more unity around some of the service related issues or things that are currently not working or are working, so that it's all kind of a little bit clarified with the data.
We did that as well with so we met with the Philadelphia Health Law Project and talked in depth about like what litigation for families look like and the data that's needed. So we also tried to ensure that if families unfortunately find themselves in a position to involve PHLP, what can we organically include in here that would allow families not to have to dig through, hundreds and hundreds of papers of documentation? What would just be available to them at their discretion if they find themselves? So we did a lot of that synergy for different systems. And again, it's for parents, it's for the caregivers. And we go back and forth, right? We didn't want to exasperate parents by having to put in too much detail or make this more of a chore than it needs to be. But we also wanted them to have the information that they may need at their fingertips, should it happen that they need it. So there was a lot that went into the questions that we're asking.
I think, some of what we've talked about today is around self-advocacy and how to take advantage of advocacy opportunities, and how can families and even, nurses and nursing agencies, how can we stretch ourselves even further to be a loud voice that needs to be heard? So I think while data entry into an app like this can seem sort of like a chore if it's not strategically designed in a way that it's not, which it sounds like you're being very diligent about making sure that it's not.
We're trying.
For users to understand, this could be your advocacy tool. This could really do a lot to help organize that information and help you advocate for yourself, for your loved one, for other families, for systems change. I think this is so wonderful. We have a pretty good amount of time left. We said we would go till 3:30. I have us at 3:10. So there's about 20 minutes of time for conversation around this. If you wanted to take some time, one thing I do want to say, you know, also kudos, high fives, all of those things for explicit. I know that this is directed toward the pediatric population now, but thank you for being proactive and sort of aware that this is something that you could potentially, and I presume you hope that it could be stretched out and expanded to other populations, other age groups, other systems of service. And I suspect that if it's successful in supporting and advocating, if it's successful in supporting caregivers who rely on shift nursing, it theoretically could be successful in supporting caregivers who rely on home health aid and personal care assistant services. So is this something you see, perhaps all things going well, you know, expands beyond the pediatric population or even just the nursing population?
So yeah, so we early on really tried to focus on our wording so that it wasn't inclusive to pediatric only, that it really, like at this point, could be used for caregivers caring for any loved ones of any age. And yeah, so we also like the wording, we do use the word nurse a lot, but we really try to focus on home health, home health aide, home health nurse. So yeah, I think we have tried, again, without being too burdensome, to be as inclusive of any population that could use this, as well as any need. You know, we mentioned like chronic need, but also those who have needs that aren't chronic, that might come up once or twice a year, and how could this be helpful for that population? And making sure that as we're structuring the app and asking questions, that it isn't it isn't turning off any sort of population, but that it could be used one way or another to track, to validate all the above. And I think it could be inclusive for anybody relying on somebody coming into their home for whether it's home health, home nursing, home health aides. You know, and I think Megan, we actually talked about this too, about like, you know, do we need to expand that to like school aides and like, so there's all these things that have floated around our idea, within our minds, trying to see how we could be as inclusive as possible without being burdensome, which is still a struggle. We're still figuring that out. That's why we continue to welcome any and all feedback, because again, this is supposed to be user friendly. This is supposed to be a tool that, you know, in the future can be helpful and again, not burdensome. So that's the biggest task we have going on right now. But I think, you know, we'll get there. We just have to, you know, as Erin mentioned, this is still being developed. We're just about done and ready to enter the next phase of beta testing. And that's, I think we'll learn a lot through this next phase about what's realistic, what's not realistic, or what's needed, what's not there. We really look forward to this next stage and making sure that we're able to hone in on those needs. Erin, do you have anything you'd like to add? I know I just talked for a while.
No, that's okay. So just to be specific, we have this feedback survey link that we hope that folks can provide. It's a Google form that we hope you can provide some input if you're in the mood right now or later. We also have been doing, we wanted to do focus groups, but because of the pandemic, we have been doing kind of one-on-one interviews sometimes, and sometimes we could organize a smaller group. But if you're interested in actually testing it out, that's beta testing. So we can only offer that to a small group of people. Our app developers said 15 or under. But if you're interested, it would be super helpful to us to get really good, solid feedback from people who are using home shift nurses in their home, to make sure that what we're asking and the functions and this, you know, and that it's all not burdensome exactly, and that it's supportive, and that we're asking the right questions. And then we are also looking for people who are willing to provide your story a little bit, because we talked a lot about story and voice today. That's also part of this app concept, is collecting stories either in short videos that would be in the app, so that to help everyone connect and to hear other people's perspectives, or in writing. Same thing. So if you're interested in any of that, or want to know more about it, or you're not sure, but you're kind of, you're wondering, just email us and we can go from there. And our emails are in the chat and also on the next slide. So we welcome any of that.
Erin and Missy, we have a question asking the estimated date of publication.
Estimated.
I feel, what do you think, Missy? Like September?
I was going to say probably fall, early fall.
Yeah.
September-ish.
The developers are putting actually the final touches on it in the next week or 2 or 3. And then we're still in the process of gathering feedback and then making some tweaks based on that feedback. So yeah, September or early October.
Yep.
That's our hope.
Yeah, fingers crossed. I know we all know how these things go. To just touch on that question, and also, well, not necessarily that question, but one from before. Should any of our government agencies, should any of these systems who support and systems who provide these services to individuals across PA be interested in building some sort of partnership or relationship in utilizing the data that's collected in some way? Is that something you foresee being able to potentially handle in the future?
So, it's kind of unknown, right? Like, I would love to say yes, but I'm not sure. We'd really have to see. Obviously, we would hope this data, I imagine this data, should it be robust, will be desired amongst many systems, because it'll show trends on either end, and maybe influence a greater conversation with real change. With that in mind, we're just very protective of the families we serve and the data. So it would have to be a larger discussion, I think, amongst us, at this point, it's Milk Crate that we're working through and what that looks like. But it's not something off the table by any means, because we really do want this to be a tool that impacts the systems that are at play here, and that enhances the caregiver experience and overall influences positive change across each system, and that's utilizing home health nursing. So we just have to see where this goes, and then have those larger discussions, which we are more than open to.
Great. I know there's some folks here from some of those agencies and organizations. So should they be, if we just warmed up their mind oven, if they've got some ideas baking, I just wanted to let them sort of connect those dots, if you will, and see if that's something that could potentially be happening in the future. There is a question, I'm not sure if you could specifically answer this, but maybe you could answer or theorize how the app might attend to this issue. An anonymous person said some of their clients have nurses coming in late, or that want to leave early, and are having parents sign blank timesheets. This person tells their clients not to do that, but we know that situation is tenuous when it's happening in your home in real time. So if you don't mind, I'll answer a little bit about that. Number one, if that's happening, obviously we want all families to feel comfortable with the services that are being provided to them by their nurses and their nursing agencies. I know that sometimes it can feel overwhelming to complain to the nursing agency, because it's already so hard to find coverage, that a nurse who wants to leave early or come in late is sometimes better than no nurse at all. But I urge parents and caregivers and those who support them to please make the special needs units aware of behaviors like this and issues like this. But before that, give the agency the opportunity to address the issue. I know it's scary to complain about your nurse right now because we need sleep and we need to be able to go to the doctor and take our other kids to school and do all the things that we need to do. But it's unacceptable for a parent to be put in a position where they have to choose to lie to their agency and to the payer of the service, or to lose that nurse. One of the potential, I would say, one of the potential things coming down the pipeline that could address an issue like this is that all agencies at some point, at least all medically, and Dana, correct me if I'm wrong, all medical assistance funded agencies by a certain time frame will have to implement an electronic verification system where even if they're still charting on paper, the sort of the verification of the shift delivery will have to happen electronically. So theoretically, paper timesheets being handed to you blank won't be something that a nurse could do anymore. But that's obviously not right now. So, you know, please, for folks who are experiencing an issue like that, or who have clients or people that they represent who have issues like that, if they want to connect with an advocate one-to-one, reach out to us, PA Families Need Nurses Now, and we'll try to connect you with the right resource to help a family deal with that situation. But thinking about how the app might attend to something like that, is there a way that you might see that being a benefit to a family in an odd situation like that?
Yeah, and Missy, feel free to chime in, but there's a section within the app where people can input data like that. If people are coming late to work, falling asleep on the job, using their phone too much, all those kinds of things that might impact care communication, and the impact or impacting the family in some way, all of that can be documented. But of course, this is all on the user. So if the user wants to document data, they have to know it's on the honor system of whatever they input in there is their own data, right? So however they put it in is, no one else is verifying what the family's putting in either, right? So if the nurse comes late, the family puts in that they came late, then that is documented there, right, in the app, just like it would be on paper, right? So what I'm trying to say is it's the validity of your own data, and what you put in is what is supporting your voice. Right. So in the app, you can support your voice and how you see the situation with the data that you put in. So the more clearly you put in details and the more consistently, the better kind of case and foundation you have for a conversation about an issue, whatever that issue is, whether it's this one that came up in the chat or a different one.
And I'm just going to add, oh, sorry.
No, that's okay. We just had a question about whether, speaking about that, if the app then tracks verification or tracks the location the way electronic verification does for a situation just like that.
So currently, I answered this in the chat, we don't have like a location tracker currently, but we do ask, I think we're doing it by zip code and county right now of the location of the user. And then updates are frequently encouraged if they're needed. And that's something we can definitely talk about further down the road if like ongoing location is something that would be useful. We could definitely consider that. I also want to add on things like issues that come up, like that we just discussed in the chat. So that will all fall kind of under this category of disrupted shifts, right? And as Erin mentioned, it's up to the user to track that. But what is great about this is over time, whether it's 3 days, 3 months, 3 years, the user can report that. So you can look back and say, like, how many times did I experience a disrupted shift? as compared to how many times did I experience over the last month completed shifts that there were no disruptions, and I was very happy, and be able to leverage that as needed, and use that data in any way that might come up, especially in advocating for, you know, what's needed and what's not being met, however that looks. I know that can fall in a couple different buckets. But that's really what we're hoping to capture, because right now it's really just captured through word of mouth, and all the vigorous parents out there writing things down in notebooks. But there's no aggregated data or trends to really prove with the data. And that's, you know, one of the areas we're really trying to fill through this app.
Thanks, Missy. We still have a few minutes, so you know, I want to keep the conversation going if we can. I do want to make the point. Somebody, I think maybe it was Kelly from the Peel Center, said just to remind folks that your signature on a document like that can make a family part of a fraudulent activity, and you can lose your services. It is your signature, so please remember families and folks who support families. It's a really important thing to make sure that what you're agreeing to happened in your home actually happened in your home. So just to be mindful of that. And again, no family should ever be put into a position where they feel obligated to falsify information just so that they can continue getting services on a proximal level, from nurse to nurse, or from an agency level. So be sure to make sure. I know, again, it's very, very, very desperate times, and we're all scared to lose our nurses. But be mindful that you don't want to be the person on the hook for something that was considered fraudulent. You know, one of the things I'm just thinking now, if a family wasn't comfortable saying something in the moment, Missy, you mentioned, or maybe Erin mentioned, that the app will have the ability to take pictures of things. So, you know, if a nurse is there and they're handing a parent a blank timesheet to sign, and the parent wants to take a quick photo in the app with that timesheet, the timestamp on the photo would match when the nurse was there. So it could be, you know, the agency could then see, this was the nurse who asked me to do this. And maybe that would give families a little bit of a comfort level on how to report that information and have some, you know, some proof. So I think maybe this app will have some applications in real life and in the user realm that hadn't even been considered, in ways for families to advocate and protect themselves in some ways. We didn't get to talk a lot about the resources that you hope to share in the app, and then also the ways that you hope that it could connect families.
So yeah, so we do.
Oh, hang on. Sorry, one quick question.
Yeah,
Kelly, this is a great question. Curious, does the app track? Well, I think, does the app contact tracking of lost education? So I can answer that. Yes, to a degree, it will. Sorry to answer for you. I want to. When parents or caregivers are utilizing the app and a shift is interrupted for some way, it will populate, or it will bring up another pop-up that will allow the family to say what way they were impacted. And one of those options will be missed day of school, sibling missed day of school, things along with missed day of work. So I know for time reasons, Erin and Missy tried to keep this this presentation as succinct as possible, but the screens that families will have to fill out are actually pretty robust, and they've put a really great amount of thought into this. So, but things like that are great questions and great feedback to include on that feedback survey, that Google form that we shared in the chat. So folks, please do click on that. It's not a very long survey. And the input, after you've seen this presentation, the input that you could provide and the thoughts and the concerns that you have are going to be really beneficial, I think, to TACHIP as they continue to finalize the product. So maybe just for the last couple of minutes, if you could just talk a little bit about, you know, how you hope to share resources and connect families with the app. I think that would be a great way to wrap up.
So yeah, there's definitely, we have a whole resource section that we're completing now, that'll be ongoing, updated on an ongoing basis that will reflect which agencies offer services in various languages, trying not to make it too robust so it's not a helpful tool, but something that, you know, from the feedback we've had from the families we've worked with, from the families that we interviewed, that we're making sure we're including how, you know, what's needed, what comes up most frequently, and how to access it in an easy way. The other thing that we do have, like an activity feed that we'll call the caregiver connection, that can be used as to bridge families together, to share kind of like a Facebook feed where you can share pictures, you can share ideas, share events, that will be able to highlight stories that we're hoping to collect, as well as short clips, filmed clips of families sharing questions, sharing stories, and a way to kind of cultivate a community of family members and caregivers, and then share experience, right? Share ideas, share successes. You know, Erin and I have really tried to make a conscious effort not to only focus on the negative impacts families report, but also the positive, because there are many that come from families. So we have places throughout the app to share that as well, and really hope this will be a place where caregivers can share those positive experiences with one another, to say like, hey, like, you know, we heard today that like there's so many of these smaller, almost mom and pop staffing agencies all over the place now. Some that have really great nurses attached to them, but are not well known, so that we can start spreading the word about these smaller places that have been greatly impacting families in a positive way, so that we can highlight that and give a place for that to live. So we hope the app can do all of this. It's going to take some time and some, I'm sure, troubleshooting. But we're really excited. But what's really going to drive and make this successful is going to be the feedback that we hope to get from families and caregivers through beta testing and ongoing. So yeah, so I continue to say, we really do welcome any and all feedback, questions, ideas, and, you know, from different agencies, if there's ideas that you have, knowing paperwork and documentation, that would be helpful for us to know. We are in development now and almost done, but this is something that we can work on ongoing. So nothing is set in stone. Erin, anything? Yeah.
I just want to chime in too, the resources will be mappable. So because we serve, you know, so many counties in Pennsylvania, we wanted families to be able to see, is it close to me? Like, it's a great resource, but is it close to me? So that's just a little additional piece. And I also wanted to thank several people who are in this audience who have really helped us think through a lot of this, and really provided some valuable kind of background information on how some of these systems work and what's important to weigh and consider. So that's just a general thank you, but you know who you are. Thank you.
Second that, thank you.
You know, we're just thrilled that there's an organization like yours who's really focusing a lot on the caregiver experience for those who utilize shift nursing. I think, you know, TalkHIP, when PA Home Vent program turned into TalkHIP, it had some years of growth, and you two in particular, and Natalie, and I think some of the other folks there have really driven it back to sort of the caregiver focus and in the way, sort of the spirit that it used to have, and those of us who transitioned from one to the other feel that. So thank you. This is such a cool and potentially like wildly useful idea, and I'm excited to see it grow. And for those of you who wanted to provide feedback, I dropped the link in the survey. I'm sorry, I dropped the survey link into the chat again, so you didn't have to go scrolling back for it. So it should be pretty recent in the chat box. Someone is asking if a certificate of attendance will be issued. We're not necessarily a CEU certified type of event, but we can explore that with you. So please feel free to email myself or Victoria. Victoria, if you don't mind throwing our email addresses in the chat box, we can figure out how we can confirm that you attended today. For everybody who's still hanging on, thank you so much for attending today. Thank you so much for being a part of the work that we're all doing and for advocating, supporting, and just self-advocating. Families like mine and Victoria's and those across Pennsylvania who rely on in-home nursing, we're really hopeful. We're exhausted and we're worn thin, but we are hopeful. And as it's been said multiple times throughout the day, we have this once in a lifetime thing happening on a nationwide level, where legislators at the federal level and the president himself is talking about home and community-based services and the home health workforce and how to restructure how we value those things. And this is rare and it might not come around again. So we need to make it happen now. This is our time. So thank you for all being a part of that. And we look forward to, please keep an eye out for a survey about the summit that will come automatically from Zoom if Zoom is agreeing. We will also be posting the slides and all the materials in the video from today on our Facebook page and our PAFamiliesNeedNursesNow.org page as soon as we're able to upload it. And we look forward to seeing everybody next year at the 2022 summit, maybe in person. So thanks again, everyone. Be safe, be well, stay healthy, and keep advocating.